Please move this window away from second window. AC would go on. Good afternoon, everyone. Welcome to again today's webinar. And this is a special webinar because we have taken some new topics, which is latest in the management of the COVID-19. As usual, the case number is increasing. Today again, I'll update you about the latest numbers, and I'll also tell you the latest issues in the management of the patient. We have enhanced bed numbers. Kotak has started another COVID hospital in Jagatpur with dialysis and the delivery facilities. Similarly, Bhubaneswar has started, Barampur has started, Sambalpur has started, and we have additional ICU bed and additional facilities for our patients. And also in the treatment, we are looking to the latest guidelines. And you know, the coagulopathy is an important issue in management of COVID-19. Besides the pneumonia, which is a viral pneumonia, most of the shadows in the X-ray and the CT scan are because of coagulopathy, pulmonary thromboembolism, and they disappear very first once you start with the anticoagulants. So in this session, we have taken a presentation on coagulopathy, which will tell you the basics of thromboembolism in a patient of COVID-19. And to start with, the hematological manifestation, the attachment of the COVID-19 virus with the heme part, and how the patient gets anemic, how the hematological system is affected, which one of the most important pathology in making people sick will be taken up in coming session also. And following that, we have the usual presentation of home isolation. Many people prefer the home isolation guidelines because now more and more people are going for home isolation. They must know the do's and don'ts. And Professor Pani will be presenting the home isolation from here, followed by the antivirals. Now there is a craze for antivirals because more and more people are staying at home. They are thinking that they should take some medicine, and they have shifted from hydroxychloroquine, azithromycin, doxycycline to favipiravir. So they want that they'll purchase it from market. Many patients are approaching us for a prescription because it's not available without the prescription, and they're very keen to take some antivirals. So you must know where is the place of antivirals, maybe oral favipiravir or injectable remdesivir. With that topic, again, Dr. P.K. Thatoi is coming to present you the antivirals. We have a very interesting case, as usual, from Dr. Shampat Das from Ashwini Hospital at the end. We have invited our DMET sir, Professor CBK Mohanty, and sir has sent all his good wishes. He is, as usual, busy in the meetings. So with his nod to go ahead with the attendance and approval of Department of Health and Family Welfare, and also our Dean and Superintendent, I'm starting the session with this introduction, and we have Professor Pani will be joining soon. Professor M.R. Patnaik will be joining soon. Dr. P.K. Thatoi will be joining soon, and Dr. Shampad will be joining from the Ashwini Hospital. Our full panel will be ready in another 15-20 minutes, and I'm sure you'll enjoy today's session as well. So this agenda is before you, and as you see, we are starting with the first topic, the coagulopathy in COVID-19, and followed by the antivirals, and then home isolation and case presentation. Keep your questions ready. The whole program is streaming in the YouTube. The YouTube link is also sent to you, and here also in the chat box we'll put the YouTube link. And as usual, your questions will be taken for discussion. And besides the topics of presentation, you can also take any other issue in any COVID hospital for the purpose of discussion with our panel. So thanking you all for your interest. Again and again, you have shown interest and joined with us. We see 100 plus patients, around 114 participants by now with us. And with this, I request our team members to share the slides of the first presentation, the coagulopathy in COVID-19. So this is to start with the presentation. As you know, this is 6th month. We are going to complete August, and still the number is on. The whole world is burning with COVID-19. And today's world data, we have 2 crore 35 lakh. It's going to be 36 lakh very soon. So it's almost 2.36 crores of patients worldwide. More than 8 lakh people have already died in the world, and we have 1 crore 60,000 patients who have recovered. Am I audible to everyone? Can you please write in the chat box? Yeah. So I request our team members to type the link in the chat box. YouTube link somebody has interested. Yes, sir. Yeah, it has come. Yeah. इसी प्रथमे आरंभ ही नथला था. So YouTube link chat box से type करो. This is what we are discussing. Out of 2 crore 35 lakh patients worldwide, 8 lakhs are dead, and 1 crore 60 lakh patients have recovered. The recovery is important because that shows the way we are moving ahead. And you know, when the recovery reaches 75%, usually we decide that the peak has come, and the peak followed by off peak, and the recovery rate crosses the number of aided patients. So in the country, we have already crossed 31 lakh patients, and the death rate approaching 60,000, that all of you are aware. And by this time, out of this 31 lakhs, 23 lakh patients have already recovered. In the state, we are past 81,500 around, and deaths are 419 with 54,406 patients who have recovered already. So with this background of the problem, I'm telling you the hypercoagulability and why we should discuss it. Initially, when the whole world was moving around the pneumonia, viral pneumonia, a concept came from Italy where they conducted autopsy on many patients, which was usually not done because of the infectivity. They did it, and they saw widespread thromboembolization, which was significant of DIC. So they told this disseminated intravascular coagulation is a very important finding in the autopsy. So we should think of a coagulopathy, and then came the role of D-dimer, then came the role of thrombin, then came the role of testing the blood for hypercoagulable state. And in the treatment modality, we added low molecular heparin, unfractionated heparin, even the oral anticoagulant drugs. So there, that is the history, and we don't have much time to decide whether the treatment modality is recommended or not recommended in view of pandemic situation. It's all off-label treatment that is recommended for the treatment of the COVID-19. This novel coronavirus presents with various phenotypes that all of you know, which ranges from asymptomatic to profound rapid multi-organ dysfunction syndrome and death. That is the surprise. Many patients, they have uh, no symptoms at all, but there are patients who at the time of detection are going to hypoxia, multi-organ failure, the PF ratio is falling very first, in need of ventilator, and they're deteriorating. The several mechanisms have been proposed for the multi-organ dysfunction syndrome in affected patients, of which a hypercoagulable state with micro and macro. We have evidence of microinfarctions and macroinfarctions, the circulatory thrombosis, which plays an important role. The disseminated intravascular coagulation has been reported to be a strong predictor of mortality. Widespread is the DIC, increase is the mortality, and almost two-thirds of the non-survivors are found to have DIC in autopsy and the further follow-up. So this is the criteria for DIC detection and the treatment. And the basic pathophysiology, I'll just focus here, that in the vessel, after there is a cytokine storm or the cytokine release, there occurs cell death. Many lymphocytes die and we get lymphopenia, and there occurs a fibrin mash with activated platelet, and they cause vasoconstriction and all vascular effect with binding to the heme part of the hemoglobin, and also they are responsible for causing a disseminated intravascular coagulation. And this is how a virus enters the pneumocyte, type 2 pneumocyte, with S2 inhibitor. And if you see, the vascular permeability is increased, the mediator are increased, there is cytokine storm, and there occurs a lot of alveolar edema causing deposit of the fluids in the lungs. So you know about the different types, the L and H types, the low elastance type, where there is low VQ ratio, long recruitability, and the weight is also low, and different strains are also determined of now, where the severity is determined, the symptoms are determined, and also the proneness to thromboembolism is determined. With this background, let us see the venous thromboembolism in COVID-19. A study shows up to 50%. This was a study conducted in the ICU, where almost 50% cumulative incidence of thrombotic complications, mainly changes seen on the computed tomography, the pulmonary angiograms, and even if the RT-PCR is negative, even if the antigen test is negative, if you go for a CT scan, if you go for a X-ray, you'll get a classical picture, the bed wing appearance, and the peripheral consolidation will be there. That those are mostly contributed to thromboembolism, not because of consolidation of pneumonia. The D-dimer level was remarkably high, given that all patients received at least standard doses of prophylaxis. So in a routine testing, it was found to be high. I'll tell you more about D-dimer. Other studies from France and the Netherlands, where they have a better control on the disease, suggested that the thrombosis occurs on almost one-third of critically ill patients, even after the prophylaxis is given. This is the X-ray of one of the first patients at Cuttack at Ashwini Hospital. We have shown it many times. You can see this peripheral pneumonia, viral pneumonia, and how on day 4 things have resolved. do you think that a consolidation pneumonia will resolve on day 4? It's unlikely. So maybe this is a anticoagulant effect, the low molecular heparin effect, which has helped us to come over the thromboembolic phenomena in the lungs, and we have got this clearance. This is also this started picture of the patient of the COVID-19, and this classical picture of the peripheral consolidation. And in the CT scan also, when you see the peripheral consolidation, they are more akin to the pulmonary thromboembolism than to the viral pneumonia. So with this background, the rationale for using anticoagulant in COVID-19 came. The pathophysiology associated with respiratory disease is consistent with pulmonary vascular thromboemboli with increased dead space ventilation, because white
slide the count. Stop.
So the pathophysiology of COVID-19 associated with respiratory disease is consistent with pulmonary vascular thromboemboli with increased dead space ventilation, because lot of space is occupied because of the thromboembolic uh, complication of the COVID-19, the increased dead space ventilation they take place. And the autopsy studies have revealed venous thromboembolism in deceased coronavirus patient that I have already talked at the beginning. So early anticoagulation is required to prevent propagation of microthrombi at the disease presentation, and it communicated clearly that the low molecular heparin, the unfractionated heparin, and also oral drugs have a role in such type of patient. And anticoagulation may help in reducing mortality in patients, especially though in them where the coagulopathy score is more than 3. Okay. I'll show you a very important diagram of different phases. And the severity in the severely ill patient, the viral response gradually comes down and the host inflammatory response takes up. So you can divide it into 3 stages: the stage 1, stage 2, and stage 3. Where in stage 1 it's early infection, where you get mild constitutional symptoms of fever more than 99.6 degree Fahrenheit, dry cough, diarrhea, headache, and in clinical sign we get lymphopenia, increased prothrombin time, increased D dimer, and LDH. So the therapies are in the spectrum: remdesivir, hydroxychloroquine, convalescent plasma, and initially we reduce the immunosuppression, and subsequently we promote the immunosuppression when the host inflammation has taken place. The corticosteroid, the human immunoglobulins, the interleukin 6 inhibitors, interleukin 2 inhibitors, the JAK inhibitors all come in the second phase when the host inflammatory response is predominant. In stage 2, you can make it 2A and 2B depending on the pulmonary phase, and there you get a shortness of breath, hypoxia, that's PaO2 FiO2 ratio less than 300, were discussed many times, and abnormal chest imaging, the transaminitis, and low normal procalcitonin. And stage 3, there is hyperinflammation phase. You see the transition. Initially, the virus is causing havoc, but when the disease progresses, the viral load comes down and host takes up. And it's host inflammatory response to the virus which causes problem, which causes cytokine storm, which causes thromboembolic phenomena, and which deteriorates the patient, causing hypoxia and shock. So here in this phase, we have ARDS, SIRS, shock, cardiac failure, And in investigation, you get elevated the inflammatory markers, the CRP, LDH, interleukin 6, D dimer, ferritin, troponin, pro BNP, etc., etc. And here comes the role of corticosteroid, interleukin 6 inhibitors, etc. So this is the classical phase of COVID-19, and these patients are at particular risk of thrombosis because it causes massive inflammation, boosting cytokines which increase the liver's production of clotting factors. The fibrinogen level in a severely ill patient usually 10 to 14 gram per liter, when in a normal person it's 2 to 4, and in a pregnant woman it increases to 5 to 6. So the blood is almost sticky in these patients. This is another beautiful chart telling you the risk factors, the inflammatory response, the hemostatic abnormalities and clinical outcomes. You know the risk factors, the acute illness, the patient is in bedridden state, so there are thromboembolism, the genetics, the fever, the diarrhea, the sepsis, liver injury, the CKD, COPD, heart failure, malignancy are the risk factors, and the tissue factors like decreased TFPI, lymphopenia, and increased IL-6 and CRP, they come into action. The hemostatic abnormalities, which I have been hammering again and again, are the pulmonary microthrombi, intravascular coagulopathy, the myocardial injury, and increased cardiac biomarkers. And there occurs increased D-dimer, the FDPs, and the prothrombin time, decreasing the platelet, results in venous thromboembolism, myocardial infarction, and DIC. So this is the path where the problem moves on. And what is D-dimer? Many of you are not very acquainted with the D-dimer. It's a degradation product of cross-linked fibrin resulting from plasmin cleavage. And the tests are used to help us rule out the presence of an inappropriate blood clot, that is thrombus. Some of the condition that D-dimer test is used to help out include the DVT and the pulmonary embolism. So that indicates of such a situation in the patient. And you can see from fibrinogen to fibrin mediated by factor 2A, this is a pro-inflammatory signaling, and fibrin to D-dimer mediated by the plasmin, which is very important. And finally, from fibrinogen, the D-dimer results. And after the thrombi clips fibrinogen into fibrin monomers, the monomers can align and are allowed for cross-linking by means of covalent bonds in response to the activated factor 13, calcium, and platelets. So plasmin degrades the cross-linked fibrin to fibrin degradation products, including D-dimers, and it can be measured using monoclonal antibodies and serves as a diagnostic test for ruling out thromboembolic diseases in specific patient population for monitoring DIC. So that's why it has become a needed investigation, and along with the prothrombin time, along with the LDH, along with the procalcitonin, along with the other markers like interleukin 6, we do a D-dimer in every of our patients. So what does this elevated D-dimer mean? A positive high value results may indicate the presence of abnormally high level of fibrin degradation products. So we are getting a indirectly a level of fibrin degradation product from the D-dimer, and it indicates that there may be significant blood clot formation and breakdown in the body if it is high. You can see from these parameters of PaCO2, PaO2, and SO2. So this is a very important diagram where the survivors and non-survivors are plotted. When the D-dimer is high, is more than 1 microgram per ml, had a higher mortality than patient where the D-dimer was low. So you can see as the D-dimer goes up, the mortality goes up, and in the survivors this is almost at the baseline. The non-survivor, the D-dimer goes up and up, and there occurs more thromboembolic complications. With this, I have come to the last part of my presentation, the thromboprophylaxis. We have evidence that the thromboembolic phenomena is a routine phenomena in COVID-19 patients. And we have also seen how to test that, how to quantify that, and how to see that the patient has a better outcome. So finally, we'll see how we can plan our thromboprophylaxis. it's reminded that all confirmed or suspected patients admitted to the hospital should be treated with pharmacologic venous thromboembolism prophylaxis given the high inflammatory state, unless there is a specific contraindication for such therapy. And here is a very nice chart from Sinai anticoagulation algorithm. If a patient is admitted with moderate or severe symptoms, if there is a patient is high risk, there is increased oxygen requirement, increased D dimers, increased creatinine, increased CRP. A patient, you have to see whether admitted to ICU or not. If patient is admitted to ICU, you have to go for heparin drip. That is for pulmonary embolization. That is the PE protocol. We go for PTT 70 to 110 or enoxaparin subcutaneous 1 milligram per kg BID or 40 BID, and we consider the DPA protocol as well. And if there it's no, then you can go for if the high risk is not there, you can go for oral anticoagulant or enoxaparin 40 milligram OD. And if the patient is not admitted to ICU and the creatinine clearance is more than 40, then you can go for enoxaparin 40 twice a day subcutaneous. And if the creatinine clearance is not more than 40, less patient on renal replacement therapy, dialysis, then you have to plan for heparin drip or oral drugs like apixaban. And if this is no, then again the corrected dose of enoxaparin and apixaban. So in this patient, you have to get a CBC, PTT, D dimer, and you have to hold coagulation if platelet count is less than 50,000, INR is more than 1.5, and evidence of current recent bleeding is there. The patient takes the anticoagulant at home. There are few algorithms to monitor, and the rivaroxaban, the apixaban, and dabigatran, they are also used in patients who are more or less stable and discharged with these drugs at the time of discharge. Also for the prevention, we give this. Discharge COVID-19 patients on therapeutic anticoagulation when hospitalized. So there we consider the anticoagulant for 2 weeks. You can consider the oral drugs. So this is the final guideline that I'll explain for you. This is from the Boston Medical Center, and you can see the patients are classified into low risk, intermediate risk, and the high risk. Low risk are having no venous thromboembolism or other indication for anticoagulation, and the D dimer is less than 2000 nanogram per milliliter, and the milder disease severity. There is acceptable bleeding risk with no bleeding or profound thrombocytopenia. With platelet below 25,000, their platelet is usually higher than 25,000, or severe coagulopathy risk is not there. So in them, you have to see again the creatinine clearance is more than 30 or less than 30. If it is more than 30, comfortably you can start with enoxaparin, and for 40 milligram once daily for BMI less than 40, 40 milligram twice daily for BMI more than 40 when weight is around less than 120 or more than 120. So this is the standard intensity enoxaparin prophylaxis in patient where the BMI is taken into consideration, creatinine clearance is taken into consideration, and risk factor is taken into consideration. If they have low creatinine clearance, unfractionated heparin is preferred, and 5,000 when the BMI is less, and 7,500 the BMI is more. So intermediate risk is very high D dimer. That's more than 2000. Here it was less than 2000. And the moderate to severe disease, that is the PF ratio less than 300, SIC score more than 4, SOFA score is higher, and risk of bleeding deemed to be acceptable for more intense prophylactic coagulation, and thrombosis risk likely persist beyond lab finding following below the threshold. So the creatinine clearance is more than 30, then increase the intensity of enoxaparin prophylaxis. It can be given up to 70 milligram twice a day if patient is more than 130 kilos, and if the creatinine clearance is more than 30, less than 30, their unfractionated heparin is given with infusion of 8 units per kg per hour. So finally, the high risk patients are full anticoagulation. In confirmed patients of venous thromboembolism, established reason for therapeutic anticoagulant, like the patient having a prosthetic valve and other risk factors, and then the patients who are having the heart disease with clotting, or dialysis tubing, or lines resulting in repeated interruption, high clinical concern for DVT, for pulmonary embolization, but unstable, otherwise unable to undergo the confirmatory testing. There again, creatinine clearance more than 30 and less than 30. More than 30, as usually go for enoxaparin 1 milligram per kg twice a day, or 40 twice a day. Unfractionated heparin in patients with low creatinine clearance, the bolus and start PTT goal of 55 to 90, and if not on anticoagulation, 80 units per kg bolus, then infusion of 18 units per kg per hour for BMI less than 30, or 15 units for BMI more than 30. It can be planned in this patient, the intravenous route. And if transition the transitioning anticoagulation regimens like this category, consider consulting the pharmacy, and you have to consider the 10A level and the response to treatment of the additional thrombosis suspected. So in this patient of low risk, consider trending D-dimer and repeat risk of stratification, because if it's increasing maybe to less than 2000 initially, but it's rising, you can consider here. Here the ICU patients at intermediate risk, consider screen for DVT with different focus in the body. And the pregnancy refers to the Boston guidelines, obstetrics venous thromboembolism guideline, where this may consider 3 to 5 weeks of prophylactic enoxaparin for symptomatic COVID postpartum patients. So these patients are given the enoxaparin even after the discharge at home, domestic setup. And in these very sick patients, the COVID venous thromboembolism screening in a patient with rapid increase in D-dimer, that's more than fivefold in 48 hours, or acutely worsening oxygenation, increased dead space, we have to consider the empiric anticoagulation, how bleeding risk is there. So you have to stratify the risk, decide the renal function, decide the weight, and you have to go for either the enoxaparin or the heparin. And at the discharge, you can consider jolly well the treatment which helps the patient to remain free of the complication. Because last time we are seeing the other day a case presented by Dr. Dhar regarding widespread thromboembolism. So with this, we have come to end of the presentation. This is my last slide. Who should receive anticoagulation upon discharge? Patients of high risk group who have an established indication for therapeutic anticoagulation, and they have undergone ICU stay, maybe stayed 15 days, 20 days, 1 month in the ICU. So they should receive anticoagulation upon discharge also. And one has to consider all these factors, estimating risk and benefit, making a decision for the individual patient. And it is suggested that the clinician may consider extended prophylaxis for 4 weeks upon discharge, and that is usually not done through the injectable, no, not done through the pens or the low molecular heparin, usually through the oral drugs like apixaban, like dabigatran, or rivaroxaban. So to summarize, we have come to an end of the presentation. Hypercoagulability is a part of the complication of COVID-19, responsible for morbidity, mortality in 30 to 50% of the cases. And these are the people whom we can save by starting the anticoagulant early. The guideline is you have to go as per the risk, as per the creatinine clearance, as per the BMI. You have to start with 40 milligram enoxaparin daily to 40 milligram BD. Then the patient is usually tried with other drugs like unfractionated heparin in patients who have no renal clarity for the use of enoxaparin. and these patients may be used with the subcutaneous enoxaparin or oral drops at the time of discharge from 2 to 4 weeks. So this is today's coagulopathy presentation. Please put your questions in the chat box and we'll be happy to take up again. Now we move on to the next topic, the antivirals. We have the most important thing. Many of you are confused to use antivirals in the patients of home isolation or not, to use antivirals in patient in the non-COVID setups or not. And you know, as per the government policy, the COVID patients are also staying at home and also staying at non-COVID hospitals. So they are confused whether to treat or not to treat. To speak that, I invite Dr. P.K. Thatoi, who is a senior associate professor and unit head in the Department of Medicine, SCB Medical College, and he is coming across the problems. He's a COVID warrior. He is our consulting professor for management in the technical team of the government of Odisha, and they are day and night giving service to the COVID centers regarding the management issues. Dr. Thattu will be telling you regarding the antivirals, their properties, and how their use can be extrapolated, keeping the safety and efficacy in big picture. So should you give it in a home isolated patient? Should you give it in a non-COVID hospital? Or you should give in a COVID hospital or ICU setup? And keep your questions ready. We'll take all the questions at the end as usual after the guest presentation. We present you Dr. P.K. Thatoi for the next presentation of antivirals in the management of COVID-19. Dr. Thatoi.
No. Latest. No. आपको पढ़ी
नोट पर पढ़ी डाउनलोड करा
ना
सीट लेटेस्ट
हाँ
सीट डाउनलोड करा ठीक है
एनेबल एडिटिंग करना क्या बोला
there so I'll go good afternoon namaskar so this is the second topic COVID-19 current options in antiviral treatment. So before that, everybody knows what is COVID. And before starting my topic, I will just in a glimpse highlight salient points on COVID and outline the very practical management of COVID-19. So novel coronavirus COVID-19. Coronaviruses are a large family of viruses that are known to cause illness ranging from common cold to more severe diseases such as severe acute respiratory syndrome, which is by coronavirus in 2002-2003. And exactly after 10 years, next came this Middle East respiratory syndrome, that is also by coronavirus. And nearly after 10 years, a new coronavirus emerged in Wuhan city, Hubei province in China at the end of 2019, known as 2019 novel coronavirus, which is the pandemic going on. So what virus does, this is a viral infection to human body by droplet infection. In persons, major subjects, this is asymptomatic. So those who are persons with advanced age, immunosenescence, hypertensive, diabetic, coronary vascular disease, obese persons, prior endothelial damage, inflammation, and chronic oxidative stress, there is no control over the virus. Virus goes on replicating, and in those subgroup of patients, the virus, the disease becomes more grave. So there is no control over the virus. There is inflammation and acute and chronic endothelial damage, neutrophil activation, then coagulation activation, which Professor Panda has already highlighted. Coagulation activation. There is major cases. This is my coagulation or coagulopathy in microcirculation. So COVID, one can say, is a form of uh, microthrombi or thrombotic phenomenon. So that leads to endothelial damage, barrier rupture, hypoalbuminemia. So it's the feature of severe sepsis, lymphopenia, non-homeostatic lymphocyte migration, apoptosis, entrapment. This cycle goes on. ARDS, which we have discussed, L type, A and H type, etc. So this cycle goes on replicating. And broadly, this slide, Professor Panda has shown three phases of slide, three phases of infection. Majority, 80% of our cases becomes stage 1, early infection, and patient present with mild. 10-15% goes to moderate, and 5% goes to really hyperinflammation phase. So in majority cases, so the signs symptoms are there is lymphopenia, but there is very mild elevation of all those body reacting factors. So practically, we based on CBC count, CRP is not so much elevated, LDH D dimer is not elevated because it's not in hyperinflammation phase. So this is in this phase, virus goes on, increasing its by replicating. So role of antiviral drugs has a role in this phase. Once we have come to this phase, there is body's response that has caused more damage in human body. So because of cytokine storm, aggressive pulmonary phase, in those phases, the virus load is practically less. So giving antivirals here practically doesn't mean anything. So if somebody wants to start antiviral drugs, we can think of giving antivirals in this phase only, early phase, and properly to whom we should start. Because majority of cases are asymptomatic or mild cases. So they cure by themselves. So in those cases, the signs are very less. Symptoms are just flu-like symptoms, fever or maybe diarrhea, or loss of sense, a loss of taste sensation, or loss of smell. Exactly once in 10-15% cases, this comes pulmonary phase. There is abnormal chest imaging. So there is transaminitis. There is the increase of inflammatory markers, and the very simple inflammatory marker is CRP. So we cannot as a procalcitonin, D-dimer in all places. Procalcitonin is not increased in COVID. It is if secondary bacterial infection is there, then procalcitonin can rise. So in this stage, CRP is important because we have to start steroid here. If we can assay the inflammatory markers, particularly CRP, then we can give one anti-inflammatory in the form of steroid. And as in 5 or less than 2% or less than 5% cases, around 2-3% cases, they go to very severe stage, hyperinflammation phase, elevated inflammatory markers, very high CRP, LDH, IL-6, D-dimer, ferritin, troponin, NT-proBNP. If this goes on increasing, then we can think of that is cytokine storm. This is the cytokine release, but this never happens in all patients. So don't be very panic. So, but keep an eye over CBC, CRP, if possible, D-dimer, IL-6, troponin, etc. So, what are the symptoms of COVID-19? COVID-19 practically simulating with ILI, influenza-like illness, H1N1 infection, SARI. So, fever, myalgia, cough, lack of energy, sore throat, breathlessness are common in all these diseases. But what is specific for COVID-19 in this era is anosmia, that is loss of smell or loss of taste, and patient may present with diarrhea. So diarrhea may be one of the early signs or symptoms. And the diagnostic tool, very simple. Every COVID hospital or non-COVID setup or small setup hospital where keeping COVID patients should have oxygen monitoring protocols or oxygen monitoring pulse oximeter, simple equipment. Cost is around 2,000 rupees or 1,500 rupees, easily available everywhere. In a very remote area, it is battery operated. We can judge, we can calculate the oxygen level. We can think the patient is having severe hypoxia or patient is having, though COVID positive, in a good oxygen saturation. Next comes CBC count. CBC count, a simple test available, I think, in all COVID hospitals or non-COVID areas. CBC must be there. It can predict the hemoglobin level, the TLC level, the lymphocyte level, the platelet level. So the lymphocyte percentage, it can predict in by CBC count. And as you know, RT-PCR is freely available in all government setups. With that, it is supported by rapid antigen test and chest X-ray. Chest X-ray is one of the easily affordable, easily available, portable X-rays. This should be in all COVID hospitals. And well and good, long CT, better. If it is not available, don't worry. We can manage with these things. So what more investigations? Yes, CBC and CRP are cornerstone investigation. These two, CBC, CRP. Keep always eye over CBC and CRP. If possible, D-dimer, ferritin, IL-6, LDH, because these are these investigations in cytokine storm, including CRP. In cytokine storm, there is a high elevation of CRP, D-dimer, ferritin, IL-6, so also LDH level. But these tests are not available in all small set of COVID hospitals. They can send it to special lab. Report comes 2, 3 days or 4 days after. So practically utility is CBC and CRP. Every hospital should have CBC and CRP monitoring all the time. And CRP means I mean to say this is quantitative CRP. CRP bracket Q. As we know, fraction of COVID cases, 80% or 80 to 85% cases are mild or asymptomatic. They do not need practically any treatment. 10 to 15% are severe infection requiring oxygen, and 5% or less are very severe critical infections requiring ventilation, requiring patient care. Those persons I described, those are having immunodeficient, CRF patients, any lot of comorbid conditions, they can fall in this group. And the classification of COVID patients as per Ministry of Health and Family Welfare, mild, moderate, severe. Mild patients, majority is a blessing to us. Mild fever and or uncomplicated upper respiratory infection without dyspnea or hypoxemia, they are majority cases. Moderate are pneumonia with no signs of severe disease, respiratory rate around 24, and SpO2 is less than 94 on room air. And severe cases, which comes in our 5% cases, respiratory distress requiring ventilation, respiration rate, they are tachypneic, respiration rate more than 30, SpO2 is less than 90 on room air. So these are broadly 3 groups of patients. Majority are in this group, mild group. Then comes management. I will highlight 5 management. Please keep in mind 5 management, 5 drugs available till with us easily. These 5 drugs are: number 1, oxygen by any means, nasal fronts, face mask, reservoir mask, or high flow nasal cannula. I will come in next slide. Then comes aviac proning. Very important. This is the patient part. Patient has to follow these protocols, aviac proning. Next comes, this antithrombotic part by low molecular heparin or unfractionated heparin. Maybe aspirin you can add, prophylactic and or therapeutic doses. Then the 4th one is time of inflammation. If we say in moderate, CRP is becoming high, more than 2 times of normal of CRP quantitative, then think of steroid. These drugs are wonder drugs, dexamethasone or methylprednisolone. These are available everywhere. We have good experience over dexa. Nowadays, we have good experience over methylprednisolone. We are using in many diseases, including spinal cord injury, including in nephrotic syndrome, etc. We have good experience with these drugs. Practically, these drugs are very helpful drugs and harmless drugs. Next comes the 5th one is antivirals, which I will discuss. Reduction of virus load at the proper time. We'll give antivirals. And what are the antivirals? And last but not the least, patient should be put on mechanical ventilation. Think of whether the patient is having cytokine storm or not. If storm is there, we can think of giving IL-6 inhibitor. These are immunomodulator anti-cytokine drug, that is tocilizumab. It has also many rheumatologists having good experience about tocilizumab. But the thing is that tocilizumab is not a very wonder drug. It can cause severe infection, secondary bacterial infection, fungal infection. So giving this drug is a double-edged sword. So better, unless until there is highly mandatory situations, which is become less than 1% or less than 2% cases, we can manage with this, the timing of drug, timing of oxygen therapy, timing of low molecular heparin, timing of steroid, timing of antiviral in the form of remdesivir. And other therapies are like improve the immunity, like good sleep, good food, vitamin C, vitamin D, zincs. So these are the last one things. These are adjunctive therapy to all these phases. Next comes our oxygen therapy. Oxygen by means of prongs, in nasal prongs, simple device available everywhere. All COVID hospital should have 3 devices at least, because these are not very under or unavailable things. They're quite available, everywhere available. Nasal prongs, we can give oxygen 1 liter to 4 liters per minute. If we require more than 4 liters, we cannot use nasal prong. Next comes face mask. In face mask, one can give 4 liters to 8 liters per minute oxygen to maintain the SpO2 above 94 or around 94. And if we buy a face mask, oxygenation is not maintaining, think of giving oxygen reservoir mask. These are also available. Cost is not very high cost, 300 rupees per mask. By this, we can give 8 to 15 liters of oxygen per minute. Very high oxygen we can give. Next comes HFNC or NIV. Many hospitals, COVID centers, small set of hospitals, NIV or HFNC not available. So if requiring oxygen more than the requirement from oxygen reservoir mask, one can go for intubation. That is the hospital decision. Next comes awake proning. How we can prone? Make the patient prone position. At least 30 to 2 hours proning in a flat bed, prone position. Then after 2 hours of make him to right lateral or left lateral. After that, then proning. So this sequence of exercise one can go for. This is proning. It really helps. This is costless therapy, but the patient has to obey our command. With nasal prong or nasal mask, one can go for proning. One can go for left lateral or right lateral, like that. Next comes as our viral application, pulmonary phase, and immune dysregulatory phase or severe phase. The symptoms are like this. The treatment are designed like this. When in this viral application phase, patient present with majority asymptomatic, which do not require any treatment. Fever, myalgia, cough, headache, diarrhea. If they are from mild to moderate or above, we clinically, if you think of somebody is thinking it is at the end of mild or above mild, like the situation, or moderate position, one can go for antiviral. So antiviral in the form of oral favipiravir. If it is moderate to severe, think of remdesivir, it is injectable form. And another option we have in the first phase is, if oral favipiravir is not available, one can think of ivermectin plus doxycycline. This is also recommended. Our government of Minister of Health and Family Welfare recommends still in mild cases hydroxychloroquine also still been recommended, though the recovery trial or other trials fails its utility. But government of India is still recommending in its use in prophylaxis, so also in mild patients, those who are diabetic, senior, age more than 60, with kidney problems, one can think of giving hydroxychloroquine, unless until the person is having QT prolongation issue or cardiac problem or arrhythmia in the past. With that, vitamin C supplementation 500 milligram BID, and we can suggest add zinc and vitamin D 2000 unit daily. And if the person presents with in the pulmonary phase or with moderate to severe phase, think and is inflammatory markers becoming increased, and CRP is more than CRP is one important marker here. CRP more than 2 times with hypoxia, think of giving anti-inflammatory in the form of methylprednisolone. Methylprednisolone 1 milligram per kg BID, that comes around 40 to 80 milligram IV BID 7 to 10 days. With that, to prevent thrombotic phenomenon, enoxaparin 60 milligram per day. If the person is still hypoxic and going towards ICU, enoxaparin 1 milligram per kg BT. So subcutaneous BD. With that vitamin C, etc., and antivirals here in this phase. Antiviral in the form of no oral, it is form of injectable antiviral remdesivir. So these are our topic, antivirals. So these are different antivirals trusted, uniponavir, then lopinavir, ritonavir, etc., etc. Next, the trials or RCT in favor of these two antivirals, favipiravir and remdesivir, which block the reverse RNA polymerase, RNA-dependent RNA polymerase enzyme. By this blocking this enzyme, it prevents the virus proliferation. Here also hydroxychloroquine helps in the membrane fusion and preventing endocytosis of the virus particle. So favipiravir, coming to our oral antiviral, it is also known as Favipira or Favipiravir or commonly available Faviplu tablets, 200 milligram each tablet, is an antiviral drug being developed by Japanese company. Favipiravir is an antiviral agent that selectively and potentially inhibits the enzyme RNA polymerase. Favipiravir has shown activity against influenza viruses, West Nile viruses, yellow fever viruses, foot and mouth disease virus, as well as other faviviruses, arena viruses, bunia viruses, and alpha viruses. It has good property against all these viruses. It has proved. Favipiravir have been approved for experimental use against COVID-19 by regulatory agencies of Italy, China, and also in India. Doses is very high. Each tablet contains 200 milligram favipiravir, 9 tablets BD day 1. So it comes around 1800 milligram BD day 1. Totally day 1 is 3600 milligram favipiravir day 1. And from day 2 to 7, 4 tablets BD, that is 800 milligram BD, that is 1600 milligram total day, 1800 milligram BD from day 2 to day 7. At times, if patient is moderately or high moderately sick, one can go for 14 days. So total number of tablets required in 7 days is 66 tablets. So each tablet costs around 100 rupees. One can think of the burden of tablets one can use only favipiravir. Apart from that, other things are there. And it's used in special population, particularly pregnant women and lactating mother, one should not use because it has proved that embryonic deaths and teratogenicity have been reported in animal studies. So in the pregnant women, lactating mother, no use of favipiravir. Patient with gout or history of gout because it increases the uric acid level should not be used, or if used with caution. Children of less than 12 years age should not be used. Geriatric patient used with caution, particularly those are having renal impairment. EGFR less than 30 should not be used. Hepatic impairment should not be used. If liver enzymes goes more than 5 times of upper limit of normal, one should not use. So favipiravir has some static contraindications, and the major drawback is its cost, availability, and the amount of the things the person has to take, and given only in mild to moderate or in mild diseases where practically doesn't need any treatment. They cure by themselves. So there are some clinical trials, favipiravir versus lopinavir, ritonavir in COVID-19, an open label non-randomized control study. Lopinavir, ritonavir is not being used. It was used or planning to be used in March and April of COVID-19 of 2020. But favipiravir with interferon has some better effect. Favipiravir arm showed significantly high improvement of chest imaging on day 14. It shows also faster virus clearance in comparison to lopinavir, ritonavir. So that is there. The salient features of favipiravir are is a broad spectrum inhibitor of RNA-dependent RNA polymerase enzyme, offers faster virus clearance rate within 4 days, offers symptomatic relief within 7 days. It helps to reduce progression of disease and hospital stay, but one has to wait or one has to calculate its benefit versus its cost and availability, whether to treat or whether not to treat. Better these drugs, if somebody wants to give, it should be given in a hospital setup or in the COVID hospital setup, preferably not in home isolation. Remdesivir, yes, this is a very good drug. This is boosting our, experience of our curing patient of COVID-19. It's a broad spectrum antiviral drug developed by Gilead, it's an American company. Remdesivir demonstrated activity against SARS coronavirus, MERS coronavirus, Nipah virus, respiratory RSV virus, and Ebola virus. Emergency use of remdesivir have been approved for COVID-19 by regulatory agencies of USA, Europe, Japan, so also in India. So it's used in being approved by Government of Ministry of Health and Family Welfare. Remdesivir is a prodrug that metabolizes into its active form. Active form of remdesivir inhibits the enzyme RNA-dependent RNA polymerase, thus targeting the virus genome replication process and inhibits virus replication. Remember, it can only help if it is given in the right time, in the right dose, particularly in the virus replication phase. So in moderate to severe cases, this is given. Once the patient is having cytokine storm on ventilator, its efficacy is doubtful. On 27th June, Ministry of Health, Family Welfare, Government of India released the new treatment protocol for COVID-19. Remdesivir may be considered in COVID patients. And the government has given the clear-cut guideline when to use. If a person needs oxygenation, SpO2 to less than 94%, and tachypneic, respiration rate more than 24, with none of the following contraindications. If these are there, one should not give. Like AST, ALT, 5 times upper limit of normal, one should not give. Severe renal impairment, particularly CKD patients, or eGFR less than 30 ml per minute per meter square, or need for hemodialysis, one should not give. Pregnancy or lactating female, one should not give. Children of less than 12 years age, one should not give. The dose is 200 milligram IV on day 1, followed by 100 milligram IV daily for 5 days. IV means IV infusion, not direct IV. IV infusion, make the solution in 250 ml of normal saline, then infuse for 30 to 1 hour, 30 minutes to 1 hour. So these are the recommendations. And dose recommendation in adult patients, adult require, I said, same thing, remdesivir 200 milligram day 1, 100 milligram then after, for 5 days. If requires, we can go for up to 10 days. Adults not requiring ventilation or ECMO, maintenance single dose 200 milligram day 1, followed by 100 milligram daily for 2 to 5 days. But in severe cases, one can go for 10 days. So remdesivir is to be administered via intravenous infusion in a total volume up to 250 ml of 0.9% saline, that's the normal saline, over 30 to 120 minutes. So 30 minutes to 1 hour. So pediatric patients less than 12 years age should not be. If somebody wants to give in a pediatric age, once the person should be more than 12 years age and should be more than 40 kg. And it's used in special population, particularly pregnant women and lactating mother. No adequate and well-tolerated studies available, so one should not use. Renal impairment, not recommended in patients with eGFR less than 30 ml per minute. Hepatic impairment patients or liver cirrhosis patients should only be used in patients with hepatic impairment if the potential benefit outweighs the potential risk. Better if in those category, if the upper limit of AST/ALT is less than 5 times of normal, one can use. If it is more than 5 times of normal, one should not use. If there is transaminitis, by stopping the medication for 1 to 2 days, again the enzyme levels comes normal. In children of less than 12 years of age, should not use. Geriatric patients, appropriate caution should be exercised. So on some of the clinical trials, there are many RCTs have come up. So remdesivir for the treatment of COVID-19 preliminary report is a double-blind randomized placebo-controlled trial. Total 1,063 patients underwent randomization. Patient received either remdesivir 200 milligram IV infusion on day 1, followed by 100 milligram daily up to 9 days, or placebo for up to 10 days. So 1 arm remdesivir, 1 arm placebo, with other treatments, with supportive treatments. Preliminary results from 1,059 patients, 538 remdesivir arm, 521 placebo arm was available. Primary endpoint is time to recovery, defined by either discharge from the hospital or hospitalization for infection or control, other things. So these things, they show remdesivir was superior to placebo. So this arm is remdesivir, this is placebo. Remdesivir is superior to placebo in shortening time to recovery in adult hospitalized patients with COVID-19 and evidence of lower respiratory tract infection. Less. So this the remdesivir and placebo arm. Remdesivir has person recovered is better in comparison to placebo. So remdesivir, many rare cities have come. It's the approved drug, good drug, provided its timing of use. So in salient features, at last, broad spectrum antiviral remdesivir, selective and potent inhibitor of RNA-dependent RNA polymerase, recommended by Ministry of Health and Family Welfare in moderate to severe COVID-19 patients. Early use appears to be beneficial in COVID-19 patients. I described that the viral application phase better acts, well tolerated in both day 5 and day 10 treatment. Thank you very much.
Thank you, Dr. Thatoi. That was a complete presentation. Beyond antivirals, Dr. Thatoi has taken you to the hydroxychloroquine, to the awake toning, to the oral drugs and basics of the disease, the tests. He has told about the ferritin, he has told about the CRP, he has told about the LDH, and not only the antivirals, he has given you an overall idea of management, and this will be definitely useful for you. And I think your questions will be taken after another two presentations. Now I invite Professor Nivedita Pani, Professor Anastasia. She is very familiar to all of you, has spoken in many topics of your choice, and we have requested her to speak again on the topic of home isolation, which is a very burning topic now, and more and more people are staying at home isolation. They want to know the do's and don'ts. Now we have prepared a kit, home isolation kit, which contains equipments, which contains instructions, which contain important numbers, which you can contact and get information, what to test, when to report to the COVID hospital, and how to go further. And with this, I request Professor Pani to again cover this important topic, that all whom we are sending home, how they should stay, what they should do and what they should not do, what their caregivers need to do, and how they will be allowed with the list of numbers, and what tests like oxygen saturation, blood pressure, temperature, that they need to monitor daily. So Professor Pani in next 15-20 minutes will speak you this vital data, do's and don'ts in home isolation for COVID-19 patients. We present you Professor Nivedita Pani.
Thank you, Professor Chan Panda. So let us discuss about the do's and don'ts in home isolation of the COVID-19 patient. The guidelines by the government of Orissa, it has been done that all COVID-19 positive cases who are asymptomatic, have mild symptoms, have no comorbidities in urban areas, including urban, local bodies area, district, subdivision, and block headquarter town shall be allowed home isolation, subject to assessment of the availability of the individual room and toilet in the home of the person, and following all protocols of the home isolation laid out by Department of the Health and Family Welfare, Government of Odisha. The ward nodal officer and GP nodal officer shall be responsible for the assessment. Here, for such person, the household shall nominate a caregiver who shall agree to undertake an online or web-based training module on COVID-19 management protocols and safety of the self, household, and the patient, beside do's and do not. In case the person develops any symptoms requiring medical support or guidance, he or she shall not directly go to any hospital or public or private, but shall contact 104 helpline and follow their advice. In case of violation of guidelines or instruction of authorities, the permission for home isolation shall be withdrawn and the person shall be then sent to the government-run facility. So home isolation guidelines for the patient who are very mild, pre-symptomatic, asymptomatic COVID-19 cases, for the patient must wash hand frequently and regularly with soap and water or alcohol-based sanitizer. Do not share personal item with others. Sanitize surface in the room that are often touched. Strictly follow the medication advice. Self-monitor health and daily temperature check. So what are the guidelines? Number one is the scope. In view of the large number of the asymptomatic cases being detected, these guidelines of home isolation has been made. Which patients are eligible? The person should be very mild, pre-symptomatic, asymptomatic, And such cases should have the requisite facility at their residence for self-isolation, and also quarantine the family contact, at least separate room for the patient with a separate toilet. An adult caregiver should be available for provide care up to 24/7 basis, and communication between the caregiver and helpline is essential for the entire duration of the home isolation. And the caregiver and all close contact of such cases should take all the precautions, including medicines, prophylactic as per protocol, and as prescribed by the treating medical officer. The patient will feel an undertaking on self-isolation and shall follow home quarantine guideline. The treating doctor should satisfy himself before allowing home isolation. The house of the COVID-19 positive patient under home isolation will have a sticker affixed indicating that the house is under home isolation of COVID-19 positive cases. The rest of the family members will be in home quarantine and will follow home quarantine protocol. Which patients are not eligible? Immunocompromised patient, HIV, transplant recipients, cancer therapy, etc. Elderly patient, those with comorbidity condition like hypertension, diabetes, heart disease, chronic long liver, kidney disease, cerebrovascular disease. When to seek the medical attention when you are in the home quarantine? When you will have difficulty in breathing, deep in oxygen saturation less than 95%, persistent pain pressure in chest, mental confusion or inability to arouse, slurred speech and seizures, weakness or numbness in any limb or face, developed bluish discoloration of the lips, face and fingertips. What is the role of the state and district health authorities? The health status of those under home isolation should be monitored by the field staff and surveillance team through personal visit, along with a dedicated call center to follow up the patient on daily basis. Detail about the patient under home isolation should also be updated on the COVID-19 portal and facility app with district surveillance officer. When to discontinue the home isolation? Number 1, after 10 days of the symptoms of onset, no fever for 3 days continuously. After completion of the home isolation, self-monitor for the health for next 7 days. No need for testing after home isolation period is over. So what are the undertaking of the self-isolation? I, son of residents of dash dash dash, during this period, I shall monitor my health. I will inform the call center 104. I have been explained in detail. I am liable to appropriate action like these forms. It has to be signed by the patient, which will be countersigned by the treating medical officer. What is the instruction for the patient? Patient should at all times use a triple layer medical mask, discard mask after 8 hours of use or earlier if they become wet or soiled. Mask should be discarded only after disinfecting with 1% sodium hypochlorite. Patient must stay in the identified room away from other people in the home, especially elderly and those with comorbid condition like hypertension, cardiovascular disease, renal disease. Open the window to increase air circulation, and improving the ventilation helps remove respiratory droplet from the air. Patient must take rest, drink lot of fluids to maintain adequate hydration, follow respiratory etiquette all the time. Hands must be washed often with soap and water, which as usual, every time we are giving the training, 40 seconds, or clean with alcohol-based sanitizer, 20 seconds. And hand sanitizer, it should be with the minimum at least 60% alcohol or 70% alcohol. Hand off, avoid touching your eyes, nose, mouth, and on with your unwashed hand. Don't share the personal item with other people. Don't share dishes, cups, glasses, silverware, towels, bedding, electronics like cell phone. Clean surface in the room that are touched often like tabletops, doorknobs, handle, light switches, handles, desk, toilet, faucets, sinks, electronic with 1% hypochlorite solution. The patient must strictly follow the physician's instruction and medication advice. The patient will self-monitor his or her health with daily temperature monitoring and report promptly if develops any deterioration of the symptoms. To summarize, what ill people should do for you are ill with fever and cough, clean hands frequently with soap and water or with alcohol-based hand rub. Stay at home, don't attend work, school or public places, rest, drink plenty of fluid, eat nutritious food, stay in a separate room from other family members, but if not possible, wear a medical mask and keep a distance of at least 1 meter from the other people. Keep the room well ventilated and if possible use a dedicated bathroom. When coughing or sneezing, cover the mouth and nose with a fixed elbow or use a disposable tissue and discard after use. If you experience difficulty in breathing, call your healthcare facility immediately. What you should tell for the instruction for the caregiver? You have to take care of him because he is staying with you for 24/7. He should wear a mask. What type of mask? He should wear a triple layer medical mask appropriately when in the same room with the ill person. Front portion of the mask should not be touched or handled during use. If the mask gets wet or dirty with secretion, it must be changed immediately. Discard the mask after use and perform hand hygiene after disposal of the mask. He or she should avoid touching own face, nose, or mouth. How she will do the hand hygiene? Hand hygiene must be ensured following contact with ill person or his immediate environment. Hand hygiene should be practiced before and after preparing food, before eating, using toilet, whenever hands look dirty. Use soap and water, hand washing at least 40 seconds. Alcohol-based hand rub can be used. After using soap and water, use disposable paper towels to dry hand is desirable. If not available, use dedicated clean cut towels. Replace them when they become wet. Perform hand hygiene before and after removing glove. What he or she should do when exposure to patient or patient environment? Avoid direct contact with body fluid of the patient, particularly oral or respiratory secretion. Use disposable gloves while handling the patient. Avoid exposure to potentially contaminated items in his immediate environment. Avoid sharing cigarette, eating utensil, dishes, drinks, used towels or bed linen. And exposure to patient and patient environment, food must be provided to the patient in his room. Utensil and dishes of the patient should be cleaned with soap and detergent water, wearing gloves. Wash them with soap and hot water or in a dishwasher. The utensil and dishes may be reused. Clean hands after taking off gloves or handling used item. Use triple layer medical mask and disposable gloves while cleaning or handling the surface, clothing or linen used by the patient. Perform hand hygiene before and after removing the gloves. The waste should be disposed of as per the CPCB guidelines. To summarize, what a caregiver should do: ensure the ill person drinks plenty of fluid and eat nutritious food. Wear a medical mask when in the same room with an ill person. Do not touch the mask or face during use and discard it afterwards. Frequently clean hands with soap and water or alcohol-based rub, especially after any type of contact with the ill person or their surrounding, before, during, after preparing food, before eating, after using the toilet. Use dedicated dishes, cups, eating utensil, towels and bed linens for the ill person. Wash dishes, cups, eating utensil, towels or bed linen used by the ill person with soap and water. Identify frequently touched surfaces by the ill person and clean and disinfect them daily. Call your healthcare facility immediately if the ill person worsens or experiences difficulty in breathing. This is the caregivers. Care of the patient and family member. How will take the patient and the family members inside that house? The caregiver will make sure that the patient follows the prescribed treatment. The caregiver and also close contact will self-monitor their health with daily temperature monitoring and report promptly if they develop any symptoms suggestive of fever, cough, difficulty in breathing. So to summarize, what are the members of the household should do? They should wash hands with soap and water regularly after coughing or sneezing, before, during, after you prepare food, before eating, after using the toilet, before and after caring for the ill person when hands are visible dirty. Avoid unnecessary exposure to the ill person and avoid sharing items such as eating utensils, dishes, drinks and towels. When coughing or sneezing, cover mouth and nose with flexed elbow or use a disposable tissue or discard immediately after use. Monitor everyone's health for symptoms like fever, cough, and if difficult breathing appear, call your healthcare facility immediately. Let us see what are the do's you should do. Allocate one room. The room should have a separate bathroom. Secondly, wear mask as much as possible, convenient while staying at home, especially when coming in any form of contact with someone caring for you. Thirdly, keep your own utensil and other items of personal use in the room with yourself. Fourthly, sanitize before and after using shared spaces, specifically the bathroom. Lastly, people with comorbidity, pregnancy, weak immune system should be isolated even when they do not show any symptoms. What you should do? Do not come closer than 6 feet of the person with coronavirus. Do not use disposable masks. They should not be washed and used again. Do not come in contact with anybody without wearing a glove. Do not allow the visitors, relatives, delivery professionals, or outsider of any kind are to be strictly forbidden to come in during the time of isolation. Nobody from the household of the isolating people should go out for anything non-essential. To summarize what you should do and what should you do not do: stay home, avoid public areas and mass transit. Isolate yourself from others in your home. Use a separate bathroom if possible. Call ahead before visiting the doctor. Wash your hands often. Wear a mask, wear a face mask around other people and pets. Cover coughs and sneezes. Do not, what you should not do: go outside for any reason. Let in any non-essential visitors. Have contact with pets and other animals if possible. Share space with housemates if possible. Share dishes, utensils, cups, towels, or bedding. These are the things you should not do. Go to the doctor without calling ahead. Discontinue home isolation until instructed. Wash and dry laundry. Do not share dirty laundry. Wear disposable gloves while handling dirty laundry. Use line trash can. Use gloves when handling trash. Place use disposable gloves and other contaminated items in a line trash can. If possible, dedicate a line trash can for the persons who is sick. How to keep up your spirits while in the home isolation? Keeping spirits up while in home isolation, being in an isolation, can be stressful. Suggestions include: keep in touch with the family members and friends via telephone, email, social media. Exercise is a proven treatment for the stress and depression. Remember that isolation won't be for long. So, what are the tips you should do? Make a time to talk to family and friends. Keep up a healthy lifestyle. Make time for activities and hobbies. Self-isolation is helping for the others in communicating. A temporary, just it should be remain in your mind that it's a temporary period of isolation. Keep a routine, maintain the healthy balance, and take regular break while working. Get as much as sunlight, fresh air, and nature as much as you can. Practice relaxation, meditation, and mindfulness. Take break from the news and social media if you find it distressing. Seek professional help when needed. Reducing the boredom during isolation. When you are in a room, definitely you will feel bored. What I will do? Getting depressed. So what we should do? Reduce the boredom during isolation. Being isolated at home can cause boredom and stress. Suggestions include: arrange with your employer to work from home if possible. Ask your child's school to supply assignment or homework by post or email. Treat the quarantine as an opportunity to do the activities that help you to relax. Thank you.
Very nicely, Madam has covered the important topic. And I think not only the patients, but all of us need to revise this, because many times we need to answer many queries from our relations. And when the number of COVID patients increasing, this is affecting almost each family, and everybody has some known people, some family members infected. So they have to understand and help them doing proper isolation during this period. So that's very important message she has given, and she has taken all the pain to take the guidelines from Government of India, from CDC, from NHI, from all the sources. She has taken it and she has compiled. This has been much appreciated and circulated, and I'm sure all of you will be benefited by this. I thank Professor Pani on behalf of the SCB team. And now we'll go for the most interesting part of the session, that is the case presentation. Always we are putting cases with the intention that you listen to the story, that how patients have presented and how they are doing in their hospital stay and how they are being discharged, recovering from the situation. And always Dr. Shampad Das, who has been a very effective, productive, efficient, and academically sound in managing cases at Ashwini Hospital, has come with good cases for all of us. And the last part of the seminar, after the discussion on coagulopathy and Antivirals and Home Isolation, guest presentation by Dr. Shampad Das, the in charge of the COVID hospital, Ashwini COVID hospital, Cuttack, and she has been part of our plasma therapy, part of our many drug trials, and during this COVID pandemic, she has done a commendable job academically and professionally following up the cases that are detailed. And let us listen to the interesting case to be presented by Dr. Shampad. We present you Dr. Shampad Das, Ashwini Hospital, Cuttack.
Uh, Sir, good evening, respected all delegates. So today, this is one more case. Actually, I present many regular cases. So this is a fight for a COVID warrior, right? So this is the heading which could justify this case. So let's start with the case. This is a 59-year male with a history of return from Ganjam who developed fever, cough, and a bit of breathing difficulty for 10 days. The comorbidities was hypertension, and because of these symptoms of URTI and other things, RT-PCR was done, and it was found to be COVID positive. And the patient actually had a very mild symptoms for which he was advised for home isolation. So he was on home isolation with all the symptomatic medications and other things. However, on day 7 of the home isolation, actually he started to feel a bit breathless, and he was not able to move around of his room. Hence, the patient was decided to be admitted to a COVID hospital and was referred to our hospital. So whenever a patient who comes to any of the hospital, the first and foremost part is something about the categorization of it. That this I have talked in all of my case presentation, and I really emphasize on this thing because this is something which will guide you from the beginning. Because if the initial part you miss the scenario or you are late in treating the case, you will end up in more trouble. So talking a bit on mild, I have already talked that it is something called as fever, cough, or sore throat. That is patient having upper respiratory tract infection symptoms. Moderate is something where the chest X-ray shows signs of pneumonia, or there is infiltrates on chest X-ray, but the patient may be asymptomatic also. But X-ray findings is suggestive of a moderate lesion. Patient having respiratory rate more than 25 per minute and saturation less than 95% in room air is a moderate case. The severe are any person who is requiring any type of mechanical ventilation, whether it is non-invasive or invasive, and patient having respiratory rate more than 30 per minute or saturation less than 90% in room air. So this is how we classify patients of COVID into mild, moderate, and severe. And talking a bit about the high risk cases, that is where the history comes into play. That is, you must be aware that these are the patients where the chances are that they may land up in a difficult scenario. That is patient with age more than 60 years, patient who are hypertensive, diabetic, immunosuppressive, that is taking any type of medications which can cause the immunity to go down, patient having any of the chronic diseases like liver, lungs, kidney, and patients having cardiovascular disease, and patient with morbid obesity. So these are all the things which are high risk cases, and you must be very, very careful when you find these things in patients. So talking about it, we all know that this is a serious case because when the patient actually came to us, the pulse rate was 112, the blood pressure was 110 by 80 millimeter of mercury, the respiratory rate is 28. So it fits into the criteria of moderate thing, but if you look for the saturation, it is 80% in room air. That indicates that this patient is a severe case because patient having saturation less than 90% is severe. So he was immediately started on oxygen from the ward go. So put on oxygen and was shifted to the ICU because it's a severe case. The ABG was done, which shows a pH of 7.45. The PO2 was 66. The PCO2 was 34 and lactate was 1.5 and bicarbonate is 24. So what I always talk, because most of I receive cases who are a bit critical or moderately critical. A patient who are critical, the three things is mandatory. You need to put on oxygen first. Oxygen is a drug and it has to be given first. You have to get an IV access and put the patient on a monitor so that you are able to know what is going on with him. Record the vitals. Saturation, I already told, is always an important parameter because that will guide you or will tell you early before the patient actually goes bad, because please remember these are happy hypoxic, means they may be having a low saturation but they may not be complaining that thing. And ABG, if at all available, is a must if your patient is having a saturation of less than 90%. So next, what the patient goes to the ICU. Oxygen, I have told, is a drug, so that is the first treatment to be put before you do anything, before that IV access is done, before you connect the chest leads, connect the oxygen, because that is something which gives relief. We use azithromycin once a day. This is a severe case, as has been talked by Tarit sir, as it talked by Thatoi sir, that regarding this antivirals and other things. I am talking this is a severe case, and the remdesivir is the drug which has to be used. We have used antibiotics, that is cefpoperazone, because please understand that this is a viral disease. This is not a bacterial sepsis where starting meropenem or teicoplanin or very high dose of antibiotics will help you. Steroids, I preferably use methylprednisolone 40 mg twice daily was started. Enoxaparin, because the patient is a moderate, so we have started with 40 milligram once daily, but later it was changed to 40 milligram twice daily after I get the PT, APTT, INR reports, because I always prefer to use anticoagulant once a day and look for any bleeding diastasis. If it is there, then they may need to be stopped. So that's why I always prefer to use once a day till I get all the reports, and then I change it to twice daily. And vitamin C and zinc, obviously this has to be given. So whenever in the ICU, what we talk, or the patient is having hypoxia, these three things is always in our mind. Whether oxygen to be increased, whether we need to connect to an NIV or an invasive ventilation. So whatever said and done, oxygen is always first. Whether you are planning for an NIV, you are planning for an invasive ventilation, irrespective of it, put the patient on an oxygen with a reservoir bag, that's a must. And it is the first treatment which I have already shown you. Talking a bit about non-invasive ventilation, me personally, I am not very fond of this NIV in specifically these cases, because in a critical care, the fundamental we have been taught, has been told everywhere, is that there are few contraindications for NIV, and the first and foremost contraindication is pneumonia. So obviously, this is a COVID. You get features of pneumonia, the lungs compliance is bad. So NIV actually I don't prefer much, because it has got very limited role. Only patients who are COPD with mild pneumonia features, there I use it. But personally, I don't like NIV in COVID because that requires more supervision. You have to be there with the patient. The team should be able to intubate early, because it's not that you just can run inside the ICU and intubate, because you have to wear PPE and everything, and your trained manpower has to go. So it takes around 15 to 20 minutes time, which is difficult. And many a times it sometimes gives you a false sense that, okay, the patient is good and everything is okay, but that's not so. So NIV, in my opinion, has very limited roles, and it has to be strictly avoided if you think that a patient is having altered sensorium. There is hypoxia, the PF to FI2 ratio is less than 150. There is hemodynamic instability and organ failure features. So if these things are there, NIV is to be strictly avoided. So this is the chest X-ray on day 1. So you can see this is a typical COVID type of case, where there is a bilateral peripheral dense shadow with a bit of central clearing, but more or less both upper, mid and lower zone, as per the X-ray which we decide, the upper, mid and lower zone is affected, and it's obviously a serious type of COVID appears. So coming out of the case a bit, this is something which is to be tried in all patients, which we say awake proning. So patients who require a bit of higher oxygen, maybe more than 5 liter, and even with 3 to 4 liter also, try proning, because it actually helps. So what is that you need to make the patient prone for 60 to 90 minutes, and then left or right lateral decubitus for another half an hour, and again comes back to supine. So this is how we do it in our ICU for all oxygenated patients. That is must, it has to be done. But one thing I want to tell, that there is a few tendency that to prone patients with NIV, that should, in my personal opinion, that has to be avoided, because sometimes if the patient vomit, because you are going to press the abdomen, so sometimes if the patient vomit, the NIV is going to push all your vomiters into the lungs. So please do not, means in my personal opinion, do not try to prone by putting patients on NIV. This is a very, very important aspect I want to talk. So the investigation was done. The TLC is 12,500. The TPC is within normal range. Urea creatinine normal. Potassium a bit high. CRP was higher, and interleukin 6 is also high. So what I want to talk is that there is a bit of inflammation, and this could be the reason for which the TLC is a bit higher. So on day 2, what we do is that whenever a patient comes, we start with remdesivir, start with steroids, start with oxygen and everything, and see for a day. On day 2, actually, with all this treatment, because the oxygen requirement continued to remain high, we decided to go for a plasma. So means the way we do is that we give the patient at least 24 to 48 hours time with all the treatment that is available, and if that or with all these treatments the oxygenation part remain to be high or the patient has not improved much, so there comes the role of plasma, because remember, plasma is for early part of the moderate cases, so these patients fit into it. So 1 unit of plasma was given. So talking a bit about the plasma, it is actually a new type of therapy which has to be given in especially early part of the moderate to severe disease. And ABO compatibility is a must. IgG titer is being means measured at RMRC. We actually give plasma under strict supervision, because don't think that it is a very safe thing, because there is chance of further deterioration of the oxygenation part, or the patients can have a bit of fluid overload or rally. So please remember, when you are giving plasma, be sure that there is someone there to take care or to intubate if at all requires, because there is a chance that oxygenation will deteriorate and the lungs compliance will go bad. So don't think that's a very safe drug. So use it with a proper supervision. And the dose which we give is the 200 ml start, which is the available, and it can be repeated after 24 hours if the patient do not show a good improvement. So what happens is that, coming back to the case, on day 3 actually the oxygen requirement suddenly started to increase and the saturation started to fall. The saturation was 88% with 15 liter of oxygen. The respiratory rate increases to 40 per minute. The patient was drowsy but arousable. The pH ABG was done, which shows a pH of 7.3. The carbon dioxide was 49. The PO2 has come down. The lactate has gone up. So these all ABG shows that these are features of incipient respiratory failure. So with all these things, actually the patient was intubated and put on ventilator. Why ventilator? Why not NIV? I would say, please understand that I have told that drowsy means any patient with altered sensorium is an indication not to put an NIV, and the patient has become drowsy but arousable. The carbon dioxide has started to go up with a respiratory rate of 40. That means he is not able to ventilate himself. And with a lactate of 3, that means there is a respiratory fatigue going on. So all these things indicate that this patient is in incipient respiratory failure, and on the top of which I have already told that I have a restriction for NIV, so if the patient was intubated, and 1 more plasma was given because the patient has deteriorated. So what we do is that if at all we want to give plasma, it has to be given within 24 hours of intubation, if at all you want. Otherwise, patients who are on ventilator for 3 days, 5 days, multiple organ dysfunction, don't give plasma, because that will not benefit you. So the mechanical mode which I put preferably is the PRBC mode. So I always start with FI200 and come down of it. My target is always to get 60%, because patient, if require more than 60% of FI2, there is a high likelihood to have oxygen toxicity. So I've started with a tidal volume of 480 ml. I'm using a 6 ml per kg body weight. The predicted body weight as per the length was found to be 80 kg. I've increased, I set a respiratory rate of 25 per minute. The patient need to be sedated and paralyzed in the initial 48 hours. That's a must. So the ABG was repeated. The PO2 have actually increased a bit with FI2 of 80%. The carbon dioxide has come down. The lactate has also come down. So this is what I prefer in my modes. And closed suction, no nebulization and viral filters. This is something which I always talk about. Please do not be in a hurry to give nebulization, because these are not obstructive airway disease. These are restrictive, where the alveoli are filled. So this is something to do with the compliance of the lungs, not with the obstruction and airway obstruction. So don't be in a hurry to put nebulization, because that will cause more harm, because the PEEP will go away once you put the patient on nebulization. So that's something to be taken care of. So this was on day 3. You can see the shadow is actually still the same, and this increase in the lucency of it is maybe because of the PEEP which I was using. So I started with a PEEP of 12 and later came down. So this increase in lucency is probably could be this, but this peripheral shadow is still the same. So the target in talking about the same thing which I always talk is there are some targets in the mechanical ventilation, and we should be aware of it. It is not that just putting a patient on ventilator will heal him. So you need to adjust the ventilators for a proper care and a proper outcome. So what we target is a tidal volume of 4 to 8, so preferably 6, but it is predicted body weight, not actual body weight. We target a inspiratory pressure of less than 30, but sometimes may have to go high, but that's a different part of it. I don't want to discuss much on it, but try to have a plateau pressure of less than 30. Hypercapnia, I sometimes permit, but the pH should be between 7.3 to 7.45. The driving pressure I prefer is less than 15. And ECMO, if at all is to be offered, it has to be offered in centers who are expertise in it. So that's something which is there. Talking a bit about theory aspect of it, but please remember, ventilator you have to change as per the patient requirement. That's a must. So this is something called as proning with a ventilator or a endotracheal tube in situ. So it's done for in severe ARDS where you need for 14 to 16 hours a day. But if patient is having any of the hemodynamic instability like vasopressors, or patient is having tachycardia, any of them, please don't go for it. And suppose you have proned and the saturation falls, then revert back immediately. So all these processes which I am talking about, whether proning and other things, it must all be supervised. It is not that you just advise proning and walk off. No. So please stay there, see how the patient is responding. So ICU means it is something like assess, treat and assess. So you assess the problem, you treat the problem, you see how much it responded, and again assess the problem. So it's a continuous thing. So assess, treat and assess. So talking a bit about fluids, there is always a tendency to over or to make the patient drown in fluids. So that's something to be avoided. Try to maintain a euvolemia. Don't be in a hurry to give fluid boluses of heavy, let's say 1.5 liter or something, which is a very important part. And no gelatin, no starch, no dextran. That's must. So talking a bit about on investigation on day 5, the TLC has gone up a bit from 12,000 gone to 14,000. The platelet, urea creatinine and sodium potassium are normal. The oxygenation part have actually improved, so we are able to come down on the oxygenation part. And this is the X-ray on day 7. So you can clearly see that the density of the shadow in the periphery have started to come down, and we were able to ventilate the patient with FI2 of only 30%. So personally, what I find these days is that the X-ray and the clinical do not correlate. It is don't depend upon the X-ray to decide that whether the patient can be extubated or patient can do well. So please don't depend upon the X-ray. It is totally depends upon the clinical part, that whether this patient is able to be extubated or not. So please remember this, talking about it is something called as the fundamental of ICU care is first heartbeats. So which I always talk about, what it is, feeding. So this what I say today, I'm going to a bit elaborate of it. So feeding means try to feed the patient from as soon as possible, maybe within 6 hours of a ventilator also you can start with the feeding. Analgesia is a must, because I don't want my patient to fight with the ventilator. Sedation is a must, otherwise there will be bit of delirium which can start. Thromboprophylaxis is obviously you have to use both mechanical as well as this medicinal thromboprophylaxis. Head and elevation, at least 30-degree head and elevation has to be done. Stress ulcer prophylaxis, which we all use in our day-to-day activities. Sugar control in diabetics, this is a very, very important part, because try to maintain a sugar between 180 to 220. Don't have a very high sugar or very low sugar, because hypoglycemia is always a dangerous thing compared to hyperglycemia. Spontaneous breathing trial, whenever you are thinking that the primary reason for which the patient was intubated has come down. So in this patient, let's say on day 7, we find that the X-ray has improved, the oxygenation has improved. So we started with spontaneous breathing trial. Bound regimen means see that the patient is able to pass their motions daily, because that's very important. Otherwise, feeding may not be tolerated. Removing all catheters and lines is as soon as possible. You feel that a patient is able to maintain, remove it. And please remember, never be in a hurry to hike up antibiotics unless and until it is needed. So in this patient, I have told that the TLC has gone up, but other parameters are doing good. So I can explain that this is probably because of the steroid which I was using. This is the reason for which the TLC has gone up. So there is no hurry to hike up the antibiotics. So this is how the trend which we go through, or I have a chart in my ICU where I maintain the trend and see that how it changes. So if I talk about this patient on day 1, the important part is not oxygen, the important part is not PO2. So the most important part is the ratio of PO2 by FiO2, which is a very, very important part, and it can give you a clear-cut idea about what is going on. So let's see that on day 1, actually, the PO2 you can see is not varying much, but if you see the ratio, it is changing significantly. So don't look into a single parameter of PO2. Please always find a ratio and then decide. So on day 1, this patient have a PO2 FiO2 of 148. On day 2, actually it has come down a bit. On day 3, you can see that the PO2 has come down, the carbon dioxide has gone up, and the ratio has come down to below 100. So that indicates this is the day where we have put the patient on ventilator. On day 4, with ventilator and PEEP, the PO2 FiO2 have increased, again have increased with every day till on day 8, where we have decided to extubate. Now if someone gives me the ABG of the last 4 days, for example 80, 96, 96 and 90, doesn't make any sense if I don't have the parameters to define this ratio. So remember, whenever you are deciding something about a ventilator, this ratio is more important rather than the number of PO2. So this is the reason for which I have shown you this slide. Please look into the ratio. So this is the patient who was extubated on day 8. This photos has been published with the permission. So this is day 2 of extubation, that is today's morning. You can see that on day 1 of extubation, we were using a bit of oxygen with a reservoir mask, and on day 2, actually there was an oxygen with only mask. So I think that most of us may be knowing this person. Not to disclose further, but this has been published with the permission of it. So what I want to say is that, to conclude, is that whenever a patient comes, properly categorize that how severe is the patient, whether it's a moderate or a severe. As has been told by my previous speaker, favipiravir and remdesivir are new weapons, and but the important part is the proper patient, proper drug, and looking for his side effects is very important aspect when you are utilizing these drugs. All comorbidities of the patient must be taken care of. If he is having a cardiac problem, diabetes, renal problem, hypertension, so everything you have to take care of. Please remember, ICU is a holistic treatment. You have to treat the patient as a whole. Being a specialist, let's say a cardiac specialist, or me as a respiratory physician, so we cannot treat a part of our system. So it is a holistic view where you need to treat the patient as a whole. And lastly, what I would say is that intervene early. Don't wait that a patient will go more bad where nothing can be done, then you have done all your effort but nothing comes out. So please feel that you need to intervene early for better outcomes. So this is what the last line I want to emphasize on this topic is that please intervene early, and please treat the patient in a holistic way. That is, you need to treat the whole of a patient. So thank you for allowing me to present a case today. Thank you, sir.
Thank you, Dr. Sampath. It was a very nice presentation, and we know the of the case also. He is a much familiar. much familiar face to all of us, and good that you are saving lives by your methodical approach. And always, when we have invited you, you have given good cases of landmark cases whom we have managed very properly and have shaped their life. Again, thank you for the presentation. We will go to the questions directly, and please stay half an hour with us. We'll take up the questions. There are many questions to you also, and we will take your opinion. Mm, I'm coming from the beginning. The YouTube link is given. Yes. So the question.
Telemedicine अपने सेठी हाँ सेठी
Yes, we could use. That's it. Uh, So we'll start from here. The viral load to do anything with the inflammatory response. The first question which had come, the patients, as per the cycle threshold, we decide the viral load, and also the viral load can be independently assessed. So the question is viral load to do anything with the inflammatory response? To answer this, it's more severe is the infection, or more severe is the more high is the viral load. Usually the host response become worse, and the cytokine storm becomes worse. That's why people with high viral load are likely to go to the severe disease. Anybody want to respond to this?
No, ठीक है. That's
Yeah,
it
yeah,
depends on virus load.
Yeah. Dr. Sampad, you will tell anything about viral load?
Sir, clinically, because I don't actually have seen, don't know this viral load or something, because I mostly see a clinical part of it. What I find is that there are different types of means the behavior of the patients in different way, because sometimes I see that even mild cases like maybe around age of 80 or 89 or even 78 patients come with asymptomatic and goes away, and even 36 years male also goes down with a very high bad lungs and high oxygen and something like it. So what personally I feel means I don't have much of data to say that this may be right or this may be wrong, but what I find is that the amount of exposure or viral load do play a role in the outcome of the patients, or the patient getting more sick or something. So clinically I find this thing, but regarding whatever the yet guidelines or what the journal says, I don't know that much.
It's obvious that more severe is the disease, worse is the outcome, but correlating that with the viral load needs more study. Second question is, can we use acistrom or warfarin after discharge as anticoagulant? I have already told you the approach in the guideline. We have now approval of the low molecular heparin in patients with critical the creatinine clearance more than 30, and the patients who have a creatinine clearance less than 30, unfractionated heparin is preferred. And regarding the oral anticoagulants, few of the world guidelines, they tell the safer ones like dabigatran, like apixaban, like rivaroxaban, the safer anticoagulant who don't require a regular monitoring with PTINR, because many patients may not monitor and be exposed to the hemorrhage risk. Those who the molecules which are safer are recommended. These molecules are also there, but preferred molecules are what I told the other molecules. If after discharge platelet remains high and the 5.5 lakhs and D dimer normal, what do you advise? So, yeah.
So this is
Dr. Thato, you want to-
thrombocytosis test. This shows patient in also in reactive phase. There is infection. In infection, sepsis platelet count also goes high, pumping, and we can discharge the patient with antiplatelet very much. 75 milligram
Yeah.
aspirin for at least 3 months post discharge. You can advise, and D-dimer normal, ferritin normal. Theoretically, you can say platelet may be high. Platelet may be high can happen in infection also.
Yeah, actually, if you correlate, this is asked by Professor Subhas Mahapatra, and if you correlate it clinically, there may be a hemoconcentration, there may be platelet aggregation, and that's an indicator of body's inflammatory response, and they are more prone for thromboembolic phenomena. D-dimer may be normalized by that time, or maybe normal when detected, but it itself is a risk. And these are the group of the patient who will improve more from platelet aggregation inhibitor than from the anticoagulants, as Dr. Thato has rightly pointed out. And anybody want to respond to this? Actually, Professor M.R. Patnaik is with us, our nodal officer, head of pulmonary medicine, and I want Professor Patnaik to give his opinion regarding if a patient has high platelet count and D-dimer is normal.
Okay.
Professor S.M. Subhas Mahapatra has asked this. What is
Regarding the infection, as you told, mainly whatever the hypercoagulable stage occurs for two reasons.
Yeah.
One is inflammation, second is the hypoxia.
Sure.
Right?
Sure.
Inflammation means that the endothelial damage. There may be two type of maybe macro thrombosis or microthrombosis.
Sure.
Macrothrombosis is usually occur venous side thrombosis,
Sure.
and the pulmonary embolism also they are also associated with large blood.
Micro and macro.
Macro,
that we
micro.
discussed, we presented.
Yeah.
That we discussed.
Yeah. So that is this is important, and more of the inflammation. You correct the inflammation and correct the hypoxia, and I don't think there will be any problem afterwards.
Yeah.
So that's why some authors also told that if the patient is not taking any anticoagulant, he may not be given any oral anticoagulant, depending on the clinical status.
Sure.
We have discussed. In the presentation, we have discussed.
Yeah.
In this case, in the way Dr. Sampath has presented, so delay in arrival. 7 days he has been self-isolated. He was taking his own. On day 7 of the disease, he came. So starting antivirals or after, not in first week, I think so.
Yeah.
So far as Dr. Sampath is concerned.
Yeah, Dr. Sampath, your opinion regarding such a scenario where the platelet is increasing and the parameters monitoring the coagulation profile is normal. Are you coming across such scenario in severe cases?
No, sir. What hemodynamical means the blood parameter problems which I commonly see is that a bit of leukopenia I am seeing these days, means TLC around 2,800, 3,000, 3,200 something. Platelet sometimes is a bit low rather than a high. So platelet is more or less maybe around 80,000 to 50,000. It is something like it. It doesn't go beyond 50, means less than 50,000, or neither I have seen any patient with a platelet of very high platelets. So I can clearly say you that, for example, top one of our CDMO who got affected has got a platelet of around 80,000. One of a wife of our doctors has got a platelet of 1 lakh. But when I started remdesivir and steroids and other, because in these patients I usually give low molecular weight heparin, but a bit low dose, because there is a tendency, or there is always something in our back mind that it may bleed. But within 3 days of the therapy, the platelets actually returns to normal. So I find thrombocytopenia rather than thrombocytosis in cases.
Thrombocytopenia is a feature. Thrombocytopenia is definitely a feature of sepsis,
Yeah.
SIRS. It is there, definitely. But in few cases, thrombocytosis may be present. That shows there is infection or secondary bacterial infection is there. There may be the chance. So when there is platelet count high, also but it usually less. Usually there is thrombocytopenia. Platelet, I have seen one of my, SR's father is now being treated. His platelet count dropped down to 12,000. Then there is chance that the hematologist recommended him giving IVIG, immunoglobulin therapy, so all those things. Then platelet went up to 12,000 to 18, 24,000. In next day come down to 15,000. It was there. So with the regular treatment, platelet count bit going up. Now he is around 40,000. So
actually,
tonight I'll know.
That's clear. There may be varied situation, and you have to.
Usually there is thrombocytopenia. Usually platelet thrombocytopenia, but there is rarely it can go up. That because of infection.
We'll move on. The next question is to Professor Patnaik. The patient is asthma, bronchial asthma. They have asked. Patients of bronchial asthma, can they use the metered dose inhaler or nebulizers during the attack period? Their aerosol generating procedures.
So definitely, the answer is yes. If you are getting a asthmatic patient, if they are not even if COVID, during the COVID time, you are advised to continue their steroid inhaler. There are two actions. One is steroid when you are this is local action, anti-inflammatory local action. So usually you know that there are three phases: nasopharyngeal phase of the COVID, then is the bronchial phase, then is the third is the pneumonatic phase, and fourth is the cytokine storm. So during the second phase, if you are continuing the corticosteroid inhaler, then the inflammation will be not so much. So that's why in America there are also some group of trial that budesonide can be used whenever the patient, asthmatic patient, you continue with the budesonide even during the time of the COVID. Their symptoms is decreasing very fast. They are becoming very ephemeral very fast, and there will be no exacerbation of the bronchial asthma.
So the message is very clear. The inhalers and metered dose inhalers and the nebulizers, maybe bronchodilators and steroids to be continued with proper care for aerosol generation. You have to take.
Should not be, but metered dose.
Metered dose inhaler must take, but in sick patient when you are planning nebulization, you have to be very sure because they are aerosol generating and you can infect yourself. So question to Dr. Thatoi, remdesivir and favipiravir available under Niramaya? I don't think they are available.
It's not available in Niramaya. It is in specified COVID hospitals. It is
Actually
available in designated COVID hospitals.
they are in the dedicated COVID hospitals, and any setup who is treating such patients can indent it from OSMCL. But what the government has made provision, because government is giving this free of cost. So not non-COVID hospitals can give that. So corticosteroids increase the risk of delayed viral clearance and increase the risk of secondary infection. Should we avoid its use in COVID-19 patients?
Okay. So initially, steroid in the viral replication phase, that you are fearing that in viral replication phase or viral, proliferating phase, in those phases, if you give steroid, then proliferation will be more, theoretically, maybe. But remember, once the patient is going in the middle phase, stage 2 or stage 3, in stage 2, where the CRP is high, that is why we will judge by CRP. CRP is high. If other anti-inflammatory markers like D-dimer or ferritin is high, so then one should put on steroid, because all the trials in favor of steroid, recently completed a recovery trial with the dexamethasone 6 mg OD. They have found good result. Here we can use dexamethasone 6 mg BD at least 7 to 10 days, oblique or methylprednisolone. Methylprednisolone is the well preferred drug, also available everywhere, 40 mg to 80 mg BD. Particularly if CRP is high more than 2 times with hypoxia. Remember, repeatedly I am telling, if a person is having hypoxic, SpO2 less than 94 with room air, and also CRP high more than 2 times of normal limit, quantitative CRP, then one should put the patient on steroid.
Yeah, the most important
Not
thing.
in all cases.
Yeah, you have to detect initially when the patient has not gone to cytokine storm or the inflammatory response has not started. If you are putting the patient on steroid, it may happen that you may do more harm than good. But at the junction when patient is starting an inflammatory response, right time, as Dr. Sampath told, right time you have started intervening, you will get a result. We will take a opinion of Dr. Sampath also, but before that, a question again to Dr. Thatoi. Can we give overlapping dexamethasone with methylprednisolone?
No two steroids or two antivirals. I am a bit, enhancing the question. Not two antivirals like favipiravir plus remdesivir. No, either of the one. If somebody is on dexamethasone, because dexamethasone is easily available, it has something called, it can cause more respiratory metabolic alkalosis like things. Better, well tolerated drug is methylprednisolone. Stop dexamethasone, one can start methylprednisolone, the same dose.
Yeah. Rightly, the message has been given that you have to choose one. Many prefer dexamethasone, like Oxford University has recommended, and Dr. Sampath told they are preferring methylprednisolone. So you can use either of them. Regarding the word overlap that you have used, that may perhaps you want to know that suppose you are switching over to one steroid from other. So in that you have to calculate the equivalent dose. The different steroids have different equivalent dose that you can calculate and you can switch over, but the benefits are there in both the molecules equally if you're using in the right time in the right dose. And here I'll before I switch over, I want to need the opinion of Sampath regarding the steroid policy of the ICU patients at Ashwini Hospital. Dr. Sampath, are you there? I think he's disconnected.
Sorry, sir. My phone is not stopping, sir. Sir, please repeat the question, sir.
Actually, the question is, what steroid? When do you start steroid? Which steroid and how you go about the steroid therapy in a patient of COVID-19?
Sir, first of all, any moderate or severe cases start steroids. Means moderate means you get an X-ray shadow, recently having respiratory distress or saturation less than 95, start steroids. But if it is a severe, means that's a clear-cut indication that you need to start steroids. But in mild cases, mild means these criteria do not fit. That is, the X-ray is not there, the patient respiratory rate is normal, the saturation is normal. But if these patients continue to have fever for more than 3 days with favipiravir and other antiviral medications, and with all these supportive medication, but a fever still running high at around 100 plus, means 101, 102. Thereafter 3 days of this symptomatic medication, I start steroids, sir, with antibiotic coverage. So in mild cases, I do in this basis.
Any correlation with the CRP?
Yes, sir. CRP, I do see it. That's not an issue. CRP obviously has to be seen. What I target is CRP of at least more than 3 times the normal. But if a patient is having fever for running, means around 101, 102, there means I can give you an example, sir. Let's say about Dr. Mahanti, the microbiology, who is got admitted here, sir, 3 days back from SCB, sir. So he was initially at COVID care center, and there he is continuing to have fever and was on favipiravir for last 1 day. So I have continued for 2.5 days, but when the fever still persisted to remain high at around 101, 102, I have started steroids with the antibiotics of ceftriaxone. Now he's as means the fever has come down in 1.5 day to 2 days. But this all clinical findings, as per the findings, is not a moderate, but is a mild case. But because of this fever with a very high things and he is becoming weak because of this fever, steroid actually helps her in this scenario.
That we can give in
Yeah,
other
yeah.
diseases.
And also you have told earlier that patients having severe myalgia also steroid helps. So that's clear. Yeah. Dr.
one thing
Patnaik is
regarding the hypoxia, right? So what the one guideline is there, if a patient you are giving 3 liter or more oxygen and the saturation is less than 93, you start the steroid.
Sir?
You
Yes.
start 3 liter
Oxygen.
oxygen, 3 or more, if your the SpO2 is less than 93%.
Yeah, yes.
That's
That might be right. But hypoxia is
Yeah.
sufficient to say
Yeah.
starting steroid
Steroid.
because that is the part information
because
is going
sometimes
on.
what happens, we are giving 10 liters, 12 liters, we are getting 93%, we are not taking
No.
care with the steroid.
No.
Yeah.
So,
No.
So
there must be
hypoxia.
clean cut guideline,
Yeah.
clean cut
Hypoxia.
marking.
Yeah.
So if a patient you are giving more than 3 liters
Yeah.
and it is down to 93%, you will start.
Steroid.
So,
They have a relation.
so it's
Hypoxia, no mayor, think of steroid.
so it's relatively early, but you are hitting at the right point,
Yes.
so that you'll be able to check the cytokine storm. So thank you, Sampath. Please stay sometime with us. The next question again, Dr. Thatu has answered this. Can aspirin be used as anticoagulant agent in consumption coagulopathy in
Yes,
COVID-19?
very much. It's not anticoagulant, it's
Yeah.
antiplatelet drug.
Yeah.
We can use very much at least 3 months post discharge.
Yeah,
In
actually-
certain situations where there is thrombotic phenomena.
It's a platelet aggregation inhibitor, not an anticoagulant, but in such a situation where you see that there are high risk of platelet aggregation, and especially patients of myocarditis, you can discharge the patient with 75 milligram of aspirin, maybe for 4 to 6 weeks. So the next is, can we use antiviral drugs after 9 days of symptoms of onset in COVID-19? This is question to Dr. Thadoi.
Yeah. So preferably it's first week within 7 days because viral replication phase is decreased in after first week. So if there are some people and some hospitals, they are also starting symptomatic to 10 days. Like this, our case presented by Dr. Sampath, they have started after 7 days. I think he was there in MKCT in home isolation for 7 days. Then he came. So one can think of that. There is no watertight compartment. But 10 days is maximum. We are delaying more than 2 weeks, and patient already on ventilator on cytokine storm. So at that point, virus effect is less, body's immune response is more. So in those conditions, when we are treating the immune response, so antivirals are practically no role.
Yeah.
So we should start antivirals at the time of viral replication, at the time of virus is causing something.
Exactly. The message is the first 7 days is the viral response, and then comes the body inflammatory response. So if you start during the viral response, when the patient is going to moderate or severe state, you can check the viral load, and there can be a better outcome. If patient has gone to inflammatory phase, then even if you intervene, there is no question of benefit to the patient.
On the 9th day, there is a stoppage of the replication.
So
no need of giving antiviral.
No need. And Dr. Sampath, will you tell something regarding starting on day 9?
Sir, what I would say is that please do not think that these antivirals are something once you give every patient will survive. That's something which is that's a fundamental error that many people are thinking that antiviral delays everything will be fine, otherwise nothing. No, that's not the issue. Antiviral will decrease your viral load, that is obviously the fact, but it has to be started at the right time. Don't expect a patient on ventilator with multiple organ failure, patient has gone down, now you think that remdesivir is a life-saving drug. No, that's not the issue. What I prefer is that any patients who are having symptoms, there the antiviral roles are there. Please do not use antiviral in asymptomatic patients or those who have nothing, like some amount of cough or some amount of throat irritation. There is a tendency to antivirals, if we start, it acts like a prophylaxis. That is also not true. So it is only should be reserved for symptomatic cases, and that way in the early part, not in the late where the condition is already out of our hand. That's not.
And regarding this, I will tell, even if you suspect whatever clinically suspect as a COVID case, your RT-PCR not positive, you cannot start this antiviral drug from ethical point of view.
This is
very important.
This is the clear-cut guideline. I will, sir, add something to you, sir, with your permission. Clean-cut guideline: the person to be virus positive by rapid antigen test, or by TrueNAT, or by RT-PCR, anything, it should be positive.
Yeah.
But thing is that if I am highly suspecting and the RT-PCR time comes 2 days, average 48 hours or 24 to 48 hours, and highly I'm suspecting this is can be COVID.
You cannot start.
This is the individual's choice, the hospital
Yeah.
and individual
No,
choice.
this is already
there is
discussed
one
in
debate.
Delhi AIMS.
Yeah.
This was debated
Yeah.
because you have got other drugs. This is a off-label drugs.
Yeah.
You have got other drugs. From ethical point of view, you cannot start.
Cannot start.
Yeah.
The same thing with plasma therapy.
Yeah, exactly.
Yesterday, somebody asked, he has adequate antibody level to donate plasma, but he is never positive for RT-PCR. Can he donate?
No.
The answer is no.
No.
So you have to be positive RT-PCR for the virus, then only you can donate plasma.
In those conditions, the Maharashtra government has given guideline to their people starting 5 gravity off level in the clinic or something small set of hospitals. They are taking the written consent from the patient that my report is still negative. If something wrong,
Even if it is positive, you have to take a written consent
Yes.
about the viral because it's a
Off-label,
drug.
yeah. Because it's an off-label
Written
drug, you cannot.
You have to take it.
Yeah.
We are also using the same thing.
Yeah.
We are taking also here also taking the written consent.
What is it?
আমার जो start করছু
That was a good discussion regarding the therapy, and now we are coming for isolation. There is a question to Madam Nivedita ma'am. Why common toilet is taken as a COVID chamber and the source of infection to others?
Because in the toilet, this is a droplet infection. So when a patient uses the bathroom or a toilet, definitely he washes his face and brushes and he goes for bath and all, go for urinals and everything. So definitely when he coughs it out also, that the room will be filled with all the infection, no?
It
So
touches the knobs, door
doors,
handle,
switches and
yeah,
everything. No?
everything. So the next person will touch all those door handles, knobs, bathroom taps. From there, infection will spread.
Infection will start.
Yeah, thank you, ma'am. Actually, they will move on. There is a question regarding plasma therapy. What is the clarity about comparative study between receipt of convalescent plasma versus non-receipt of the patient of COVID-19 care of the patient in the recent global scenario? Perhaps this question has come because there is a lot of controversy, and after US FDA has stopped endorsing convalescent plasma, there is a controversy in USA as well, and many papers are coming regarding the plasma therapy is effective or not effective. But here I'll tell one thing. Many studies show the efficacy of plasma therapy as well if it started in the right time. As Dr. Sampath told, if you have started in the right time in the early course of the disease, when the patient is going from moderate to severe state and the oxygen therapy and the steroid therapy, they fail and patient deteriorates, rightly early you can plan the plasma therapy, and we have got good result out of this. So in benefit of doubt, because all the drugs are off label, benefit of doubt should be given to the patient, and we should be able to help the patient as much as possible. That is my opinion. I'll seek the opinion of Professor Patnaik as well.
So, as far as concerned the plasma, right? Plasma, it has been also it is an emergency on the basis of emergency. Yes.
EUA drug, emergency utilization.
Emergency utilization, on the basis of emergency utilization, it has been accepted by the government of India in the therapy for this COVID.
Yeah.
But recently, this American their FDC and CDC has not given a nod to this emergency utilization of the plasma.
Yeah, they have withdrawn.
They withdrawn.
Yeah.
They have
So
withdrawn.
maybe this is a politics against Trump.
Whatever is there,
Yeah.
but the CDC is not doing the politics now.
Yeah.
So they have, because in their last study they did not find any result. But as far as the India is concerned, every part is one country.
Okay.
Of India, every state is one country,
yeah.
right? So in one part of the country, the result is very good.
Sure.
In some part is not, they are not happy with the result. When you are getting the result in favor of the plasma, I think
We should continue. Dr. Sampath, what is your opinion?
So what I feel is that this plasma is giving a result. Because I was analyzing my patients. So what I found is that in around 80% of the cases, I got a good result. Whereas in 20% actually the patient deteriorated, means not due to plasma but because of the disease. So if we are getting some amount of benefit in the proper patients, it's not about plasma, it is about the proper selection of the patient, then yeah, I think it has got a role in the treatment of COVID.
So proper timing. Timing is first week.
Yeah. It's very important.
Very effective.
You have started oxygen, you have started steroid, then you have. So
Antiviral and
next question to Dr. Thatoi, how many days low molecular heparin can we use for category B and category C patients? So they have wanted, suppose you have started with this
yes,
therapy.
Category B means moderate. Category C means
Severe.
Severe. So this is the recommendation is up to 10 days, 5 to 10 days. So if category B patient symptomatically improved 5 days, one can go more than 5 days in certain cases because there is a purely in severe cases, thrombotic phenomenon will be much more.
Yeah.
Even if after discharge of these category patients, once he should put on oral like apixaban or antiplatelet like aspirin for 4 to 6 weeks together.
Yeah.
And time to time follow up. The doctor has to be in contact with him.
Yeah, actually, all the guidelines approve for minimum 8 to 10 days in these patients, and we follow up in the high risk patient of thromboembolism. We follow up them 2 to 4 weeks with oral drops as well. I would like to know about the guideline Dr. Shampad follows in Ashwini Hospital.
So in serious patients, because there is nothing like they stay for 7 days, 10 days, they can stay for 2 weeks or 3 weeks also. So in serious patient, you continue till they are mobilized or till the inflammation part goes away, because there is nothing like 7-10 days. But in mild to moderate cases, mean where I am using steroids or this antiviral like remdesivir, there I continue to use it till the day of hospitalization, because by that time, end of the day, our discharge criteria is that they must be hospitalized for 10 days and 3 days of asymptomatic. So when a patient is asymptomatic for 3 days, we think that this inflammation cascade has come down, so chances of thrombosis is less. So there I continue for at least 10 days. But suppose patient is severe where requires a prolonged hospitalization, I continue till the day of hospitalization, because that's also a DVT prophylaxis which we use it.
Obviously,
So is it treatment like or is it prophylactic dose? So BD dose or prophylactic dose?
Prophylactic, sir. BD is still the patient is on ventilator, but once the patient comes out of the ventilator, obviously the inflammation has come down. That's why the lungs is improving and other things. So there, once a patient comes out of the ventilator, following 3 days of extubation, where I think that there is again going back to the ventilator's chances are less, I change to once a day.
Yeah, Dr. Sampath, regarding this, suppose some mild cases, there is a history that they are already confound to the bed. Those cases, do you recommend for any?
Hello.
Could you hear the query?
Suppose in mild cases, there is
Sir.
previous history that he is confined to bed. And as you know, in the COVID scenario also, the patient were COVID infection positive. Before that, because of the weakness and everything, they also confined to bed. Those cases, do you recommend where you give steroids? Do you want to add those cases also for 5 days or 10 days during your stay? The prophylaxis, thromboprophylaxis in those cases?
Yes, sir. Means thing is that any patient who is a bedridden scenario, because we find patients of old age with Parkinsonism and means difficult to get out of this patient. So there, I continue the prophylaxis, and during discharge, depending upon means the financial part, which is plays an important role, I decide between whether to use dabigatran, because I preferably use dabigatran, or acetone. But that is something which needs to be explained to the patient relative, because the problem is that here there is no relative available. So whatever thing you do, once a patient gets discharged, whatever medicines you are giving, the patient has to be explained over the telephone about the effect, the side effect, the bleeding tendency. So everything that has to be explained to the relatives also, because when these patient goes out in a means moribund cases with bedridden status and everything, that is something to be taken care about the family council when you are giving these drugs of where the bleeding tendency is high.
Yeah, what percentage of cases of your COVID positive admitted to ICU are on your follow-up or telephone or anything else?
Follow-up, sir, means over telephonic consultation we usually do every 2 weeks. Instead, what we are doing, especially those who are being categorized as that they do not go out in a normal state or they go out in a bit of difficult, because you need to, I ask them to look for a pulse oximeter and saturation even after the discharge, because there is some things what happens is that some patients require a bit of oxygen intermittently, and few patients have also developed a bit of secondary infection following discharge, maybe around 1 week means after 1 week of discharge or around 10 days of discharge they develop some infection. So there is a risk with these patients. So I would say percentage means from my ICU I would say around 10% requires a bit of continuous follow-up, sir.
Hey, are they in touch or they are lost to follow?
No, no, sir. They, because we keep all our telephone and it is all done with a free of consultation. So they all pick up the phones because we talk to their relatives. Actually, we talk to their either any of their surrogates, means maybe brother or husband or son or daughter. So means they are in constant touch maybe for around 2 weeks, 3 weeks. So that's why they develop a rapport and they are under a follow-up, sir.
So what will be your advice? How frequently they should contact you? That is very important, and message should be on to the doctors as a result they can implement the treatment.
Yeah, what should be in the guideline? At the time of discharge, what should be instructed to them to remain in touch with the follow-up doctor? How frequently?
So the important thing is that there is something like various administrative part is involved in it, because the patients which you are getting are actually brought by the government, being treated by the government and sent back home in their by the government vehicle, and not a single penny is being spent. Now, if I ask for a follow-up, so where the follow-up to be done, how the follow-up to be done, and who is going to arrange for the follow-up, who is going to pay for the investigation, how are they going to be investigated. So these are all things which are there in the administrative point of view, which I think I do not stand in a position to comment on this, but that is something which needs further discussion in the administrative area, sir.
That can be suggested to government.
Uh,
Whatever is ideal, and the technical committee can.
So I would say from technical means maybe from my personal point of view, at least a follow up in 45 days and one in 6 months after discharge.
Half uh,
is there any need to enhance the medical facility for these COVID post-COVID patients?
Obviously, sir, we need to have facilities with dedicated for this part, because suppose this patient in the long run develop any type of chronic lung disease, whether some develop bronchiectasis because of its infection, whether some develop fibrosis, whether some develop some restrictive point of view, whether few develops, which we say is that chronic pulmonary thromboembolic hypertension, that is CTPH, what we say. Because I have got 3 cases from means over telephonic consultation from Ganjam. They are not actually my case, but from Ganjam. With all these things, I have asked for a echo and asked to look for the right heart contour. What I find is that their RARB are getting dilated, so they are landing in the chronic or pulmonary type of scenario. I can these are young patients. So this cardiac and respiratory follow-up, I think, is a must, because we need to see that whether they are developing secondary pulmonary hypertension, and which I think is going to be a risk factor in the coming days.
Yeah, that's very important because we have reports worldwide that pulmonary fibrosis is getting commoner that can result in pulmonary arterial hypertension, cor pulmonal very commonly even in younger patients. So, starting from pulmonary function test to scan, it will be reviewed of these patients regularly, and definitely will put a word to the right portion regarding the follow-up of these patients in the strategy and guidelines. Thank you for the opinion. Now there are a few more questions. Will go very quickly. Is there any trials with methotrexate in the COVID case? I think
No, I have not had no trial.
yeah, there is no trial. You know, this is a
And itself is a fibrogenic drugs.
yeah.
Long
So
fibrosis, causes of long fibrosis.
there is no scope
No
of this
antiviral
drug.
property.
Yeah.
There is no antiviral.
No antiviral property and
It is a
fibrogenic,
rather
immunosuppressant.
rather commoner sense. Methotrexate not to be given any kind of infection is there. Even if there UTI is there, bacterial there, fungus there, virus there, it will flare up the infection.
Yeah.
So methotrexate,
See, because
thinking of methotrexate, I think a crime.
Yeah, because it's an immunosuppressant, so we don't want to. Even off level, this is not recommended. Time of plasma therapy, adequate discussion has been made. Mild, moderate, or severe, definitely in transition from mild to moderate. And you have to, earlier is better. In a very burnt out case, there is no benefit from this. And there is a question to maybe Dr. Shampad, why awake proning is not being given so importance in the COVID ICU care? Why is the reason high death rate of the doctors in different part of the world in COVID-19? So,
It's for all, I think.
yeah, actually, the awake, the question is from Dr. Sujit Lanka, that if it is so beneficial, why not all the ICUs are practicing awake proning? I
You
think
know, awake proning is a part. I think after oxygen, the next important thing to be done is awake proning. Even if lot many cases, the COVID warriors and the persons suspicious of getting COVID are also nowadays practicing the long exercises. So awake proning is a very good, because in prone position, one goes, in the proning position, it's a pulmonary field gets more air, circulation becomes better, ventilation perfusion mismatch becomes less. So pattern I think narrative better.
Yeah. So regarding the awake proning in ICU scenario is not indicated. Why not indicated? Most of the majority of patients remaining in the ICU, there is ventilated, intubated and ventilated. There is a proning ventilation is required. Not the question of
Awake,
proning
is in ICU,
is not a scenario. But
COVID ventilator.
Dedicated COVID hospital, there oxygen there it's a definitely.
In a hospital, if patient not in ICU, in the ward or bed, he has to practice the awake proning. Once it is shifted to ICU, means patient sick, needs ventilation or some other means, etc. So
actually the timing for awake proning is when the patient has not been put under ventilator, and Dr. Shampad has made it clear in NIV patient also don't do that, so that patient can aspirate. So patient before that, and Professor Patnaik earlier has also made it clear that awake proning is not a single position. You have to go right lateral, left lateral, around 120 minutes, the decubitus and supine. So you have to keep on rotating so that the ventilation takes part.
Out of ICU one can practice.
Yeah.
But Sampath has rightly told one point, in ARDS management, so one phase before trying to ECMO or etc., one should try with prone ventilation.
So
this is not awake proning.
That
is not awake proning.
That is a prone ventilation. It is not a new thing. It is from 13 also guidelines. They started this guidelines. That prone ventilation, that they keep the patient 16 hours in that, and definitely there is a definite role.
This is not awake.
This is indicated for the severe ARDS.
ARDS.
Severe ARDS patient.
Severe ARDS, this is not awake proning. Awake proning to be practiced when the patient is in the ward. Very clear message.
Dr. Shampad, any stand on this, or this is fine? We'll go ahead.
So what I will say is that any persons requiring oxygen, means maybe 1 liter, 2 liter, 3 liter, or whatever it is, any person requiring oxygen, you can ask for a awake proning. That's not an issue. So I have told that the only important part is that mainly in obese individuals, it is a difficult scenario, and specifically don't make the patient prone after feeding them. So these are some technical point which we always forget. We ask them ke khai sara tabe proning ei jibo. Don't make it that. Always remember that making the patient prone, because they have a tendency to means deteriorate or something. So if at all you are making awake proning also, a nursing supervision is a must. In my perspective, is a must, because you don't know the patient may be drowsy, but you will be thinking that a patient is in a awake prone position. So that's something to be looked into.
Obviously, there is a chance of aspiration.
Yeah.
So that is there. But my question is, can we be in some situations proning is not possible? Semi proning can help also. In
Obviously, any type of left, right, lateral decubitus will help.
Into the NIH guideline, already
Keep on
mentioned is
rotating.
rotating.
Keep on rotating. Right lateral, left lateral, proning, supine, then you keep on rotating. So there is a question of why the reason of high death rate of doctors in different part of world in COVID-19. No, it's a war, and doctors are the frontline warriors, because directly we come across the patients and healthcare. Not only doctors, the healthcare personnel as a team are at risk, and because they are at risk, they are suffering. They're contracting the infection. Many have comorbidities. Many report late, and that is the reason. And
another factor is, main factor is the stress factor.
yeah,
Stress factor. As you know, the stress is also related to the immunity. If more stress is there, the immunity is down.
exactly.
Right.
In COVID, higher stress is being taken
Yeah,
by
the healthcare doctors.
the other day I was talking to our doctor friend. This is consecutive 6th month, and this is like
Yes.
You are in Saudi Arabia, or you are in a foreign country. People have not seen their family. You think of people who are providing COVID care. They are unable to go to family. They are quarantined. They are staying somewhere else, and staying at the same place also. They are not interacting with the family. That gives a lot of stress. That aids to decrease immunity, and the disease is usually is severe in them. Dr. Shampad, you want to say something regarding this?
Yeah.
The death of doctors. Hello, Shampad, are you there in the line?
No.
Okay, so these are the factors. One is the exposure, two is the stress, and third is the comorbidity, which makes them prone. And this is really unfortunate that many doctors have lost life. Even Odisha, we have series of doctors who are being affected and admitted. And I think Ashwini Hospital is the center which is catering to more than 20-25 doctors now who are the patients over there. There is a question: can we use fondaparinux in place of enoxaparin? Yes, you can use.
If there is no renal failure, there is no contact.
Yeah,
no contact.
if the patient doesn't have renal failure, you can use fondaparinux also.
Proper dosing is important. Once there is you can use also dalteparin instead of enoxaparin.
Yeah,
that can be used.
Enoxaparin,
So,
dalteparin,
yes,
fondaparin,
yes.
depending on
But in a renal issue, unfortunately, heparin is the best.
Yeah, if patient has creatinine clearance less than 30, heparin is the best.
Yeah.
There is a commendment of Professor Shyama Kanungo to Shampad and all COVID warriors who are working day and night, the intensivists in the government and non-government institutions. So we are passing it on from Professor Kanungo to all the team. Receiving, if a patient received favipiravir, can we consider a remdesivir?
Yes, very much. Because it's a off-label drug, favipiravir. It's all acid says many with favipiravir. It may not as comparable with remdesivir. If somebody is on oral favipiravir, becomes sick and fulfills the criteria of getting remdesivir, one should immediately change to remdesivir.
Switch over to remdesivir.
But both cannot be given. But switch over to remdesivir.
Use of ECMO in critically ill patient. Actually, there are evidences. You know about Bal Subramaniam.
But in Odisha,
yeah, Odisha.
Regarding ECMO, I will tell one thing. If you are using ECMO for a pretty long time and you are expert in that, then use the ECMO. If you are first timer or recently started, don't use. The mortality will be higher in comparison to the other ventilatory strategy. The the mortality will have.
In Odisha, ECMO, experience is not there. So we should not think of ECMO.
Last time we had presented Dr. Karunakar Padi from Kalinga Hospital was there. He has used it in Vizag in a patient.
Yes,
He was sharing that. So as Professor Patnaik told, if there is somebody expert, then it can be shared, and the noted singer is on life support, and the best possible help, at least for the valuable lives, should be available, and that also the technical committee has recommended to government. Using excess nebulizer is dangerous to asthmatic patient. You see, nebulization generates the aerosol and can be of danger to you, not patients. And there is nothing called excess. It has to be given as per the doses. So Professor Kanungo again suggested the review of COVID warrior cases who lost their lives without blame game for all COVID issues in the state to learn. So Madam has suggested that there should be analysis all the valuable lives.
Regarding this scheme, I will tell every COVID positive cases, the death report is audited and also death review is done.
Yeah.
Every case, every death case of the COVID positive case.
Yeah. Madam has wanted for the doctors and COVID warriors, but every case the death is audited and the cause is fixed, and that's why you see two categories. One is COVID and other comorbidity non-COVID. If a patient is asymptomatic but SpO2 level is still less than 90%, can we start steroids? Actually, this is classically the happy hypoxia or silent hypoxia, and the patient which started with low oxygen saturation, obviously, as we discussed, because you have detected, you can start with.
First, you give oxygen.
Yeah.
If, as I told you, if your oxygen more than 3 liters and the saturation is not increasing, definitely from the beginning you start steroid.
Yeah. What is the RO value of SARS-CoV-2 in Odisha? I think the statistician better can tell this. Trump has allowed use of plasma today. Usually, the government of USA is insisting, but there is some difference of opinion, and FDA had denied. So this is not our job. Our opinion, because it's working, we should practice, and more and more banks are being established, and plasma therapy is encouraged in the state. Role of ivermectin in the treatment.
Yeah.
Dr. Thato, you want to respond to this?
So ivermectin in the treatment, again, it's off-label drug. So three things in mild phase. Mild, those are mild symptomatic. In three options are there. One can go for oral favipiravir if available and patient is tolerated. Second one can go for doxycycline plus ivermectin. Doxycycline 100 mg BD for 7 to 10 days. Ivermectin 12 mg plus ivermectin 12 mg OD for 3 days. Second option. And the third option, one can go for hydroxychloroquine and azithromycin. Choose whatever the things. But definitely it is in mild and mild off-label drug. If somebody is symptomatic, hypoxic, start steroid, remdesivir, chronic oxygen,
Plasma therapy.
These are the choice. So far as Sir Professor Patnaik will say something.
Yeah, even if, as you know, the ICMR guideline given that in the mild cases, you don't use any drugs.
Yeah.
You keep the patient in your home isolation. But thing is that what we are observing, because there is a certain cases, if you treat in the mild stage where the viral load is less, if you again you decrease the viral load, the inflammation will be less.
Yes.
That's the idea of
That's
giving.
the idea of giving. So these are three options of antivirals in mild phase. Oral favipiravir, one option. Second option, doxycycline plus ivermectin. And the third option is hydroxychloroquine plus azithromycin. Choose where we can fit it, but it's in the mild case.
So we have completed most of the questions. The last question, which is here, is what are the contraindications for saline nebulization?
Saline nebulization. Why do you give a nebulization and why? Suppose a patient is in the asthmatic and where there is a bronchial reactivity, if you give more saline, there will be more of bronchospasm, right?
Sure.
One thing. Second thing, in the COVID, this pneumonia and other pneumonia, COVID pneumonia is usually dry.
Yeah.
If you give again the saline, that will cause more irritation, more cough, and spread of the infection. So it has got no role. Suppose there is a formation of the phlegm, thick one. You give saline embolization, there will act. But here in COVID pneumonia, viral pneumonia, there is a absolutely dry lung.
Sir.
So no use. Rather, it causes more irritation and more cough.
So no nebulization if a person needs asthmatic or COPD, it's a meter dose inhalation sufficient.
Yeah.
And that too, the steroid containing inhaler.
So with this, we have come to an end of this webinar. Dr. Sampad, you are here, still connected. I think he must have left in some emergency.
Yeah,
so I thank Professor M.R. Patnaik, Professor Nivedita Pani for their valuable presence, participation, and taking up your questions very effectively. I thank Dr. P.K. Thatoi for a nice presentation on complete overview of the management, including antivirals. I thank Dr. Sampad Das for a nice case. Always he brings a very befitting case, and if the patient is a member of the profession, that create interest in the mind of doctors also. So thank Sampad for the valuable discussion and case, and there are many good wishes in the chat box for you. And I thank all my team who cooperated. I thank Professor Mohanty, our DMET, for his good wishes, and our Dean Superintendent Shah for their encouragement. And we'll keep it on every Monday and Tuesday, as you know, now it's the infection is increasing, very difficult to do hands-on. Now this online training, including the doubt clearing session or the panel discussion, will continue for now. And I thank you for your patience, for staying so long with us. Yeah, Professor Patnaik.
Sir, I have to everybody one request: who are working in the COVID hospitals, please take care. Please always go through the IPC line. IPC, we must maintain the IPC. As a prevent all infection and also the death rate.
Yeah, that's very important
because you are all valuable persons.
And you only have asked questions regarding doctors is facing the brunt. We had jumped into the war, but we are unable to control the infection rate, and daily our COVID warriors are getting infected, and fewer very critically sick also. That is the matter of concern. So always Professor Patnaik has told you during training also that there is nothing called emergency in COVID management. First get ready, first get prepared, first be stable, put your mask, put your gloves, put your gown, put your PPE, maintain the distance, keep on disinfecting your hand, put the mask properly, and always think that you should not be infected, you should not transmit to your friends and family, and any infection may not be mild, may be severe, and there is a big question mark what happens after recovery from COVID-19. And so always take care of yourself. Thank you for remaining with us all the time. See you again Thursday. We have very interesting presentations. Professor Deepika Mohanty will be speaking about hematological manifestation of COVID-19. And we have a very interesting session on yoga and meditation in COVID-19. So what about the practices of yoga which can make you more stable immunologically and mentally? And with that, along with that, we have a very interesting case presentations as well from some hospital, and also from the Ashwini and Kim's hospital. So we'll be taking them. And I'm thankful to all of you for your cooperation, all the faculties, and finally Department of Health and Family Welfare for continuously supporting us for this capacity building program, and all the doctors who are there with us throughout the training program. Thank you all. See you again on Thursday. See you again on Thursday with new topics, new cases. Until then, bye-bye. Thank you for your participation.
Signature, sir.
Thank you.
এটা ইউটিউব লিংক আছে না নাই?
YouTube.